Assalamu alaikum. Greetings, my dear doctors, and welcome everyone to our Mrcp UK Part 1 past paper course. And our today's topic would be April 24 diet.
What is the most appropriate intervention? Ambulatory device, chest drain, conservative management, high flow oxygen, needle aspiration. A 51-year-old man with a 15 back years smoking history is admitted to the emergency department with sudden onset of left pleuritic chest pain and shortness of breath. His blood pressure is 105/70 millimeter mercury, and his heart rate is 105 beats per minute and regular. He has decreased breath sound on the left-hand side, and chest X-ray reveals 3 centimeter left-sided pneumothorax. So, what is the most appropriate management intervention?
So is it primary spontaneous pneumothorax or secondary spontaneous pneumothorax? Primary or secondary?
Seems like primary.
So how can we differentiate whether this is primary spontaneous or secondary spontaneous?
The secondary should have some pre-existing lung disease.
So in case of primary pneumothorax, there would be no underlying lung disease. And in case of secondary, there will be underlying lung disease, especially the COPD. And in our scenario, there is no underlying lung disease. So this is the primary spontaneous pneumothorax. And the patient is symptomatic with the pleuritic chest pain, shortness of breath, the size is larger, 3 centimeter on the chest X-ray. Patient is also having the significant smoking history, 15 pack year smoking history, and age of the patient is also greater than 50. So this puts the patient under the high risk criteria. So how to treat a case of high risk criteria having the high risk factors in a patient with spontaneous pneumothorax?
Chest drain.
Yes, we will be going for the chest drain. Chest drain would be the most appropriate management. So if the patient is having the significant risk factor, especially if there is shortness of breath, so previously just based on the size, they used to differentiate whether you should go for the just going for the oxygen or you should go for the chest drain. But based on the latest guideline, they are giving more preference over the symptoms, over the high risk or low risk criteria. And if the patient falls under the high risk criteria, then you should be immediately going for the chest drain. And regarding the conservative management, this is usually applicable for the asymptomatic patient with the small pneumothorax. And regarding high flow oxygen, so high flow oxygen, it should be given in all cases of the pneumothorax. This is irrespective whether this is primary pneumothorax or secondary pneumothorax. It should be given to all the patient, and it will facilitate the reabsorption of the pleural air. And this is just as a part of symptomatic management, or you can say this is an adjunctive management. This is not the most appropriate intervention. The most appropriate intervention in this case would be the chest drain. And regarding the needle aspiration, so needle aspiration, this is also indicated in the low risk cases. But here, since the patient is having the high risk cases or high risk criteria, so we'll be going for the chest drain. This patient is symptomatic from a large 3 centimeter pneumothorax and has high risk features, including a significant smoking history and age greater than 50 years. This necessitates a chest drain as the most appropriate intervention for his pneumothorax. Other features which makes up list. So conservative management, it would be applicable for the asymptomatic patient with a small pneumothorax. And high flow oxygen, it should be given to all patients with the pneumothorax. And needle aspiration, this is only appropriate for the low risk pneumothorax. In this case, the age is greater than 50 years and a significant smoking history coupled with the symptoms and size. This is considered as a high risk pneumothorax necessitating a chest drain. And in the original recall, in the original exam, The age of the patient was younger. It was around 25 to 50 years, and also that patient comes up with the sudden onset chest pain and breathlessness, and it had the same scenario. The patient had the primary spontaneous pneumothorax with a significant smoking history, and there was one extra feature. The patient had the features of hypoxia, and the size was also 3 centimeter. And in that question they ask what should be the next step. So whether this is the most appropriate intervention or the next step in case of pneumothorax having the high risk cases, especially having the shortness of breath or pleuritic chest pain, or with the features of hypoxia, you will be going for the chest drain. Okay, next one.
What is the most appropriate initial intervention? A 34-year-old woman who has recently completed a course of treatment for chronic myeloid leukemia present to the emergency department with the dull ache affecting the right hip, which she says came on all of the sudden. And she is unable to walk more than 20 meters without severe pain, and flexion and external rotation is severely limited. The MRI shows evidence of marrow ischemia affecting the femoral head. What is the most appropriate initial intervention? Core decompression with bone grafting, nifedipine, osteotomy, risdronate, total hip replacement.
So what is the most likely diagnosis?
A vascular necrosis of the femoral head.
So most likely this is the avascular necrosis of the femoral head, or this is also known as the osteonecrosis of the hip. So what should be the most appropriate initial intervention? Initial intervention of choice in case of osteonecrosis of the hip. And what should be the definitive management? What should be the initial management? What should be the definitive management?
Initial risdronate, definitive total hip replacement.
So definitive is the hip replacement, but regarding the initial management, it would be the osteonecrosis. So this type of patient, they will predominantly have the history of taking either anti-cancer drugs, or their history of taking the steroid. Steroid is the most common cause, followed by the anti-cancer drug, and patient will come up with the dull ache pain affecting the hip. There will be features of unable to walk, and there would be severe limitations on the external and internal rotation. And if you go for the MRI, there will be features of either marrow edema indicating the underlying ischemia, and diagnosis is the osteonecrosis of the hip. And the initial intervention would be core decompression with the bone grafting. The ultimate aim would be to stimulate the angiogenesis. And for the definitive management, if this core decompression with bone grafting fails, then for the definitive intervention, especially in the elderly patient, we'll be going for the total hip replacement. So initial intervention would be core decompression with bone grafting, and definitive intervention would be total hip replacement. And they will invariably have history of either taking the steroid or anti-cancer drug. So here patient had the history of taking the anti-cancer drug, and the features are suggestive of the osteonecrosis of the hip. So initial management would be core decompression with the bone grafting, and the definitive management or the last resort would be the total hip replacement. And regarding the risdronate, this is the bisphosphonate. This is used to treat the osteoporosis as well as the Pastest disease. This is not indicated in case of osteonecrosis or avascular necrosis. Osteonecrosis of the hip is the likely diagnosis here, given the sudden onset pain and the presence of marrow edema indicating ischemia. It is progressive in many cases despite intervention, but given the patient's young age, decompression with bone grafting should be attempted. The decompression procedure can stimulate new blood vessel growth, and with inclusion of the bone growth factors as part of the surgical procedure may improve the success of the engraftment. Over time, deterioration of symptoms may necessitate a total hip replacement. And osteotomy, this was the older treatment. This is no longer recommended. So rhizotomy, this is the bisphosphonate. This is used for osteoporosis and paralysis of the bone. And hip replacement, this is the last resort of treatment if the patient faced to the core decomposition with the bone grafting. And in our recall, the patient was a young age patient. Patient comes up with the 6 month of chemotherapy with the hip pain. And instead of the intervention, they asked what was the diagnosis, and the diagnosis was the avascular necrosis. Okay.
What is the most likely cause of this patient's renal impairment? Eosinophilic granulomatosis with polyangiitis, immunoglobulin A nephropathy, lupus nephritis, membranous glomerulonephritis, post-streptococcal glomerulonephritis. A 45-year-old woman is referred to the renal clinic due to deteriorating renal function. She complains of multiple joint pain and problem with the photosensitivity. Over the past few months, her BP is 152 over 90 millimeter mercury and heart rate is 75 beats per minute and regular. Her BMI is 23 kg per meter square. Hemoglobin is low, 102 gram per liter. WBC normal, platelet normal, sodium normal, potassium higher normal, creatinine 135 is raised, complement C3 is low, and urinalysis shows the blood 1 plus and protein 2 plus.
So most likely diagnosis.
Lupus nephritis.
So this patient has comes up with the small joint polyarthritis, photosensitivity. There is features of hypertension, elevated creatinine, and there is also features of hematuria and proteinuria with the low complement level. This low complement level, this is pointing towards the active lupus with the renal involvement. So SLE plus renal involvement is the lupus nephritis. So what are the glomerulonephritis that comes up with the low complement, hypocomplementemia? Glomerulonephritis with low complement level.
Okay, SLE, membranous proliferative glomerulonephritis, PSGN.
So number one are the infective condition like the PSGN, post-streptococcal glomerulonephritis, or subacute bacterial endocarditis, SLE, as well as the mesangiocapillary glomerulonephritis, also known as the membranoproliferative glomerulonephritis. And in the BMJ, two others are given complement. So post-infectious glomerulonephritis, lupus nephritis, membrane proliferative glomerulonephritis, all of them are given in the past medicine. In the BMJ, one extra is given. This is the mixed cryoglobulinemia. So in all this condition, patient will have the low complement level. And regarding the complement level, the cryoglobulinemia is the exception. In this case, there would be significant reduction of both C3 and C4. So if both of the complement level, they are significantly reduced, both C3 and C4, this indicates the cryoglobulinemia. And in all the other four conditions, like PSGN, membrane proliferative, SLE, or lupus nephritis, they will have the significant reduction in the C3. The C4 will either remain normal or it would be mildly reduced. So depending on the C4 level, you can differentiate whether this is cryoglobulinemia or other condition causing the hypocomplementemia. So how to treat a case of lupus nephritis? Choice of treatment.
Mild to moderate case,
in mild to moderate case,
mycophenolate
mycophenolate
mofetil,
mofetil, and in case of life
and in
threatening
severe
cases,
cases,
we'll be going for the
cyclophosphamide.
cyclophosphamide.
Cyc-
So if the patient comes up just with the features of SLE, no renal impairment, just isolated SLE, we'll start treating the patient with the hydroxychloroquine. In case the features of polyarthritis is predominant, then methotrexate can also be used as an alternative to hydroxychloroquine. And these two are the conventional treatment. And if the patient with SLE does not respond to this conventional medication, we will be going for the belimumab. When there is a failure on the conventional, when there is conventional drug failure, we will be going for the belimumab. And whenever SLE patient will have the features of renal impairment, diagnosis would be the lupus nephritis. In mild to moderate case, we will be going for the mycophenolate mofetil. And in the life-threatening cases, or if the patient comes up with the features of RPGN, we will be going for the cyclophosphamide. So regarding the EGPA, also known as CSS, what should be the presentation of EGPA or CSS?
There should be a feature of asthma, renal, and also the renal impairment, and also the eosinophil level will be high, and there will be mononeuritis multiplex.
Yes, very good. So patient will come up with the features of worsening asthma, eosinophilia with features of either vasculitis or mononeuritis multiplex, and in some cases there may be features of renal impairment, especially RPGN or crescentic GN. And IgA nephropathy. In case of IgA nephropathy, patient will come up with the features of hematuria 1 to 2 days after the upper respiratory tract infection. And in case of PSGN, patient will come up with the features of hematuria after 1 to 2 weeks. So after 1 to 2 days in case of IgA nephropathy, and after 1 to 2 weeks in case of PSGN. And membranous glomerulonephritis, so they will come up with the nephrotic range proteinuria, protein 3 plus. Patient will have the normal complement. Membranous nephropathy will have the normal complement. And this membranous glomerulonephritis, this is often associated with the cancer, or this is related to the underlying infection. So how to treat a case of membranous glomerulonephritis?
In case of idiopathic case, we will start with a anti-CD20, rituximab, and also calcineurin inhibitor, and also the 2C, cyclophosphamide, and another drug, corticosteroid. And in case of if there is not the idiopathic, typical variation, just the 2C.
So this type of patient usually they comes up with the features of hypertension, and whether this is typical variant or idiopathic variant. For the management of hypertension, we will be going for the AC inhibitor. And in case of typical variant, we will be using the 2C combination of corticosteroid plus cyclophosphamide. And in case of idiopathic membranous glomerulonephritis, following AC inhibitor, we will be going for the 4C in the stepwise pattern. So step 1 would be anti-CD20, meaning rituximab. Step 2 would be calcineurin inhibitor like cyclosporine. And if there is no response, we will be going for the 2C. So in case of idiopathic variant, in stepwise 4C. But in case of typical variant means they will be associated with the cancer or some other infective etiology. And the idiopathic means there would be no underlying cause, and this is related to anti-phospholipase A2 antibodies. And if you go for the biopsy on the there will be subepithelial electron dense deposit giving rise to the spike and dome appearance, and in that case we'll be going for the 4C. So in which condition we'll have the tram track appearance? In which condition we'll have the tram track appearance?
Membranoproliferative?
Yes, in case of membranoproliferative or mesangiocapillary, we'll have the tram track appearance, and tram track appearance is the subendothelial deposition. This patient has problems with the skin photosensitivity and small joint polyarthritis. There is also evidence of renal vasculitis with abnormal creatinine concentration, hematuria, and proteinuria. Remember, in case of SLE, in case of lupus nephritis, there should be combination of both hematuria and proteinuria. The low C3 concentration suggests that there is ongoing tissue immune complex deposition, which is a strong pointer to lupus nephritis. A renal biopsy is the logical next step to confirm the diagnosis, with immunosuppression as the preferred initial intervention. And EGP, they will come up with the poorly controlled asthma with features of eosinophilia, either with vasculitis or mononeuritis multiplex. IgA nephropathy, this is the synpharyngitic infection. So how to treat a case of IgA nephropathy?
APEC, SE inhibitor, P for prednisone, A for azathioprine, and C for cyclophosphamide.
So most of the cases of IgA nephropathy, they are self-limiting, especially if they comes up with the typical presentations of macroscopic hematuria. But if the patient comes up with the features of hypertension or with the poor prognostic factors like presence of proteinuria or microscopic smaller amount of hematuria, in that case we need to go for the treatment, and we usually use the APEC regimen. A for SE inhibitor, followed by P for prednisolone, followed by azathioprine, followed by cyclophosphamide. And in case of PACN, patient will come up with the features of hematuria after 1 to 2 weeks, and membranous glomerulonephritis, they will have the normal complement level, and patient will have nephrotic range proteinuria.
So, what is the most appropriate antiemetic to control this patient nausea and vomiting? A 85-year-old man who is receiving palliative care for metastatic colon cancer is admitted to the oncology ward with nausea, vomiting, progressive abdominal distension, and colic. His abdomen is markedly distended with the quiet bowel sounds, and NG tube is positioned for the symptomatic relief. So the options are the domperidone, haloperidol, hyoscine, metoclopramide, leucovorin.
Also, palliative care patient with the metastatic colon cancer presented with the features of nausea, vomiting, progressive abdominal distension, and colic. And so what should be the most appropriate antiemetic to control the patient's nausea and the vomiting? So which one would be most appropriate? So domperidone, metoclopramide, and the flucloperazine, all of them has got the gastroprokinetic, they have the gastroprokinetic effect. So they usually lead to increase in the GI tract smooth muscle tone, and they will increase the contraction. So these three drugs, they should be avoided in a patient with the features of obstruction with the biliary colic. So we'll be avoiding domperidone, metoclopramide, flucloperazine, these three drugs. With respect to haloperidol and hyoscine, so hyoscine is the muscle relaxant anticholinergic drug. This is only effective in the management of colic. This is not effective in the management of in relieving the nausea and vomiting. And in the palliative care patient, whenever the patient comes up with the features of nausea and vomiting, or in case of nausea and vomiting which is induced by the metabolic causes, we will be going for the haloperidol, especially in the palliative care patient during the life of end care. So this is a little bit difficult question. Also in the palliative care patient with the features of nausea and vomiting, or in case of metabolic causes of nausea and vomiting, for example in case of uremia or hypercalcemia, this nausea and vomiting, this is often triggered by the dopamine D2 receptor in the chemoreceptor trigger zone. So for this reason, we'll be using the dopamine D2 receptor blockers, which is the either haloperidol or levomethomazine. Usually, haloperidol is used as the first line. If there is no response, then in that case, we can also go for the levomethomazine. And levomethomazine is more appropriate as a broad spectrum antiemetic. And this is also the first line in the last days of life. So this haloperidol is the D2 receptor antagonist. Haloperidol is the intervention of choice for patients with nausea and vomiting who are receiving end-of-life care for the bowel obstruction. This is usually given as a stat dose of 2.5 mg subcutaneously, followed by 2.5 mg over a 24-hour period. The dose may be up-titrated to 5 mg over 24 hours. Hyoscine is also given to relieve the symptoms of colic. Dexamethasone can have the additive effect in reducing the nausea. So domperidone, metoclopramide, flucloperazine, they have the gastroprokinetic effect. So they are usually avoided with the symptoms of obstruction with the colic. And this hyoscine is only suitable for managing the features of colic. This is not suitable for the management of the nausea and the vomiting. And in our original scenario, in the original recall, the patient was on chemotherapy. Patient presented with the features of nausea and vomiting. Patient also had the abdominal distension. And with respect to the antiemetic, the exact question was which mode of action of the antiemetic we should be avoiding. So we will be avoiding the drugs that causes the increased gastric emptying, like the domperidone, metoclopramide, flucloperazine. So since they asked regarding the which groups of antiemetic should be avoided, so the answer would be the increased gastric emptying.
Excuse me, sir.
Yes, please go on.
Yeah, if the option would have been ondansetron, should we go for that or haloperidol?
Ondansetron is more suitable for the post-chemotherapy nausea and vomiting. For the post-chemotherapy nausea and vomiting, but in the palliative care patient, especially in the last days of life, we have two options. Either you should go for the haloperidol or levomethomazine, because in the palliative care patient, the nausea and vomiting, this is triggered by stimulation of the D2 receptor. So haloperidol or levomethomazine, this would be more appropriate. And the ondansetron acts on the serotonin receptor, 5-hydroxytryptamine receptor. So it would be more preferable to go for the haloperidol or to go for the levomethomazine in the palliative patient.
Okay, sir. Thank you.
So, what is the most likely cause of this patient's symptoms? Adjustment disorder, agoraphobia, depression, mysophobia, and the obsessive compulsive disorder. 52-year-old woman is brought to the psychiatric clinic by her husband. He is concerned as she seems to be very keen on washing her hands multiple times per day and refuses to leave the house. Her mother died from MRSA infection following a hip replacement 18 months ago. The patient refuses to sit in a chair, and when asked to do so, she starts to cry and says she believes she will get the MRSA. So what is the most likely cause?
So most likely cause of this patient symptom, is it obsessive compulsive disorder or this is mesophobia?
Mesophobia.
Yes, so the most likely cause of this patient symptom is the mesophobia. This is one of the specific phobia involving the excessive fear of specific germ or contamination. So in this case, the patient has the excessive hand washing and refusal to sit on a chair due to fear of contracting with the MRSA following her mom's death from the MRSA. This strongly suggests the fear of specific contamination, the MRSA. So this is consistent with the mesophobia, which is an intense or irrational fear of specific germ. And in case of obsessive compulsive disorder, patient will also have the repetitive behavior like the repeated hand washing. But in this case, this is typically driven by the intrusive or unwanted thoughts like the obsession. And in this case, the patient's behavior, this seems to be more linked with the specific phobia of contamination rather than an intrusive obsession seen in case of obsessive compulsive disorder. And regarding the adjustment disorder, so this is one of the impaired adaptive response with respect to the psychological stressor. And this type of patient, they usually comes up with the features of either emotional or behavioral responses to a significant life stressor, and this exclusively occurs within the 3 months of onset of the stressor. But in this case, the incident occurs 18 months ago. And in adjustment disorder, usually the response, this is usually out of proportionate to what might typically be expected, and it also leads to the significant impairment in the social functioning. So her mother state from MRSA, this is one of the significant stressor, but it has occurred beyond the 3 months period. And this adjustment disorder, this typically presents with the emotional distress or depression. This is not related to a specific fear or phobia like the mesophobia. Regarding agoraphobia, so this usually involves fear of being in a situation where the escape might be difficult or helps unavailable, like in a crowded place, which is often leads to the avoidance of the public spaces. And regarding depression, so patient with depression, they usually comes up with the persistent low mood, loss of interest, and other affective symptoms. So the most likely diagnosis would be the mesophobia. So what should be the choice of treatment in this patient? First line management in the case of mesophobia.
CBT.
Yes, we'll be going for the CBT in all the psychiatric condition. In all the psychiatric condition, except in psychotic disorder, the initial intervention will always be the CBT, cognitive behavioral therapy. After that, we can go for the pharmacological therapy. Mesophobia is specifically a fear of germs. In this case, it seems that the death of her mother due to MRSA has made the patient develop a phobia of catching the disease herself. This is manifested by a refusal to sit down on a chair in the hospital. CBT is the initial intervention of choice to manage the mesophobia. An adjustment disorder is a maladaptive response to psychological stressor. Patient often feel severe emotional distress with an increased risk of self-harm ensuing. And also remember the 3-month transition period. Following the stressor, the patient will come up with the features within 3 months. Although this patient has had an abnormal response to her mother's death from MRSA, it has manifested as a phobia rather than with the features of adjustment disorder. Agoraphobia is a fear of leaving location which an individual knows or considers to be safe. This patient's inability to leave the house might suggest agoraphobia. However, the mention of MRSA confirms that this specific fear of infection is the basis of our symptoms, making mesophobia the most likely diagnosis. Features of depression such as decreased appetite, early morning awakening appear absent here. The symptoms are most consistent with the specific phobia or the MRSA. And OCD patient will have repetitive behavior, including hand washing. Although this behavior is usually related to germs or cleanliness in general rather than to a specific pathogen, this patient's symptoms are more consistent with the mesophobia. And in the original recall, it was actually a scenario of OCD, obsessive compulsive disorder, and patient just comes up with the repetitive hand washing with the intrusive features, with the features of obsession.
So what is the most appropriate way to manage this patient glucose control? Dapagliflozin, gliclazide, linagliptin, neutral protamine, hagedron insulin, semaglutide. 62-year-old man is reviewed in a diabetes clinic. He has hypertension and mild heart failure and has failed to tolerate metformin due to diarrhea. The blood pressure is 155/85 millimeter mercury. and the heart rate is 74 beats per minute and regular. His BMI is 32 kg per meter square. Hemoglobin normal, WBC normal, platelet normal, sodium, potassium, creatinine. Creatinine a bit high, everything will be normal, it's normal. And glycosylated hemoglobin, HbA1c, is raised 63 millimole per liter.
So choice of anti-diabetic drug in a patient with heart failure.
It's the glyphosins.
Yes, so we'll be going for the SGLT2 inhibitors. SGLT2 inhibitors. So whenever the patient comes up with the features of diabetes plus heart failure, especially with the low ejection fraction heart failure, or with the features of CKD, we'll be starting with the SGLT2 inhibitor, since they have got both cardioprotective effect as well as the renoprotective effect. So they usually causes the reduction in the blood pressure. They also reduces the risk of cardiovascular disease. They also reduces the risk of progression to CKD. And usually all the other anti-diabetic like the sulfonylureas, pioglitazones, the gliptins, DPP4 inhibitor, as well as the insulin glargine, all of them are contraindicated whenever there is features of associated heart failure, since all these drugs they usually either lead to water retention or salt retention, making them unsuitable. So diabetes plus heart failure with or without CKD, go for the SGLT2 inhibitor like the dapagliflozin or canagliflozin. So what are the adverse effects of SGLT2 inhibitors? Common adverse effect.
Euglycemic ketoacidosis,
So patient will come up with
UTI,
the euglycemic DKA, and other important adverse effect.
UTI.
UTI,
Yes, patient will have the UTI and other adverse effect. Most probably there is
Fornix gangrene.
yes, Fournier's gangrene also occurs. Euglycemic, and most probably there's another one. Glycemic DKA. So they will comes up with the normoglycemic decay. They also causes the total cholesterol elevation of both HDL as well as the LDL. And since they work by reducing the glucose reabsorption in the proximal convoluted tubule, there will be increased urinary excretion of glucose, and this is responsible for the UTI as well as the increased urine output, and in some cases with the features of weight loss. So UTI is important, but the most important one is the normoglycemic decay, and they also causes elevation of HDL as well as the LDL. This patient has a mild heart failure and an elevated creatinine concentration against the background of type 2 diabetes. In this situation, given that he has failed to tolerate metformin, SGLT2 inhibitors such as dapagliflozin is the most appropriate next step according to the NICE guidelines. The SGLT2 inhibitor class has a positive effect on the renal and cardiovascular outcome in patient with or without type 2 diabetes, reduces blood glucose concentration, has a modest positive impact with respect to the weight reduction. Gliclazide is a sulfonylurea that promotes the weight gain in type 2 diabetes patient. Gliptins are the DPP4 inhibitors, and this NPH, this is the long-acting insulin.
What is the most likely cause of this patient's symptoms? Alzheimer's disease, depression, Lewy body disease, multi-infarct dementia, normal preacher hydrocephalus. A 70-year-old man attends to the memory clinic with his wife. She is concerned because he has been misplacing items around the house. walking very early in the morning and then sleeping in the day, and has twice called her from the local shop saying that he is lost. He retired from his job at the family solicitors 2 years ago, saying that he was finding the place too fast. Neurological examination is unremarkable. He scores 24 out of 30 on a mini mental state examination. So, what is the most likely cause of the patient's symptoms?
So most likely diagnosis. How can we differentiate between the different types of dementia? What is the commonest cause of dementia?
Alzheimer's disease.
Yes, Alzheimer's disease is the commonest cause of dementia. So this type of patient, they usually comes up with the gross memory loss. So the features of apraxia, and if you go for the CT scan, there will be features of the cerebral atrophy, and this is usually the commonest cause of dementia. Frontotemporal dementia, they usually comes up with the features of sexual disinhibition. Sexual disinhibition is the cardinal features of frontotemporal dementia. They will also comes up with repetitive checking as well as the binge eating. And Lewy body dementia, this is one of the Parkinson plus syndrome. Patient will have features of Parkinsonism, features of dementia, plus the cardinal feature is the visual hallucination. In some cases, there may be auditory hallucination, but cardinal feature is the visual hallucination. And in case of multi-infarct dementia, there will always be history of the associated vascular event or a cerebrovascular risk factor with the cognitive impairment. And this scenario, this is related to the Alzheimer's disease. So how can we differentiate whether this is mild, moderate, or severe Alzheimer's disease?
By the MMS score.
Yes, based on the
if this
MMS score, we can differentiate whether this is mild, moderate, or severe. So what are the criteria for mild? What should be the score?
In case of mild, it will be less than 24, but it will be more than 19. Below 19 to 10 is moderate, and below 10 is the severe.
So usually greater than 24, this is regarded as normal cognition, and in between 19 to 23, this is usually regarded as the mild cognitive impairment. In 10 to 18, this is regarded as moderate cognitive impairment, and less than 9, this is the severe cognitive impairment. Or simply you can remember less than 10 is severe, less than 20 is moderate, and above 18 or above 20 is the mild cognitive impairment. So how to treat a case of mild Alzheimer's dementia? Choice of treatment.
In case of mild to moderate,
Donepezil.
donepezil reverse sigma
Yes,
galantamine,
for the
the
mild
cholinesterase
cases,
inhibitor.
for the mild Alzheimer's disease, we'll be going for the cholinesterase inhibitor. So we can either go for donepezil or rifostacin or galantamine. And in case of severe Alzheimer's disease, what should be the choice of treatment?
Memantine.
Yes, we'll be going for the memantine. And if a patient with Alzheimer's disease, having the mild Alzheimer's disease, they have the features of bradycardia, resting bradycardia, or AV nodal block. Also in that case, we'll be going for the memantine. So memantine is either for severe Alzheimer's dementia, or if there is associated a contraindication to the cholinesterase inhibitor. So what is the mode of action of memantine?
NMDA receptor antagonist.
Yes, this is the both memantine and ketamine. Both of them are the NMDA receptor antagonist. And donepezil, rifostacin, galantamine. All of them are the cholinesterase inhibitors. So regarding Lewy body dementia, so patient will have the features of Parkinsonism, and there would be visual hallucination. So what are the types of Parkinson plus syndrome, and how can we differentiate between the condition? What are the Parkinson plus syndrome?
So it's progressive supranuclear palsy and multisystem atrophy.
So usually these three are most important for the exam: the PSP, progressive supranuclear palsy, multisystem atrophy, and Lewy body dementia. In case of Lewy body dementia, the name suggests dementia. There will be features of dementia, but always remember the visual hallucination. Visual hallucination is the cardinal features of Lewy body dementia. How to treat a case of Lewy body dementia? How to treat a case of Lewy body dementia? Anyone?
Same as Alzheimer.
Yeah, same as the Alzheimer's disease. We'll be going for the acetylcholinesterase inhibitor like donepezil or rifostacate. So they will come up with the features of Parkinsonism, features of dementia, visual hallucination. And the dementia in Lewy body dementia, this usually follows an specific pattern. There would be progressive cognitive impairment, there would be fluctuating cognition. So it would be progressive and it will also be the fluctuating. And regarding the MSA, multisystem atrophy, also known as the Shy-Drager syndrome, patient will have the autonomic features. There will be either a postural drop of blood pressure, there would be bladder or bowel dysfunction, or there may be erectile dysfunction. So either postural drop or there is erectile or bladder bowel dysfunction. This is such type of the MSA, multisystem atrophy. And in case of PSP, they will come up with the features of P. There will be postural instability, there would be pulse, especially the vertical gaze pulse. So postural instability, vertical gaze pulse, these two are the cardinal features of PSP. This PSP, this is also known as the Stille-Richardson-Olszewski syndrome. And what should be the triad in case of normal pressure hydrocephalus, NPH triad?
Dementia,
Doug.
urinary incontinence, and gait disturbance.
Yes, they will come up with the features of DUG. There will be features of dementia. There will be features of urinary incontinence. And there will be also features of the gait apraxia. These three are the features of NPH: dementia, urinary incontinence, gait apraxia or disturbance. And if you go for the MRI or CT scan, there would be hydrocephalus with an enlarged fourth ventricle. And initial intervention in case of NPH, it would be the therapeutic lumbar puncture. Remember, this is not investigation. Therapeutic lumbar puncture, this is not initial investigation, this is the initial intervention in a patient with NPH. And to differentiate NPH from the MSA, multisystem atrophy, we will be looking for the autonomic features, autonomic dysfunction. This is the cardinal features of multisystem atrophy, like orthostatic hypotension, urinary incontinence, erectile dysfunction. And there will be also presence of cerebellar syndrome. And in case of MSA, there would be absence of gaze pulse. Gaze pulse is the cardinal features of PSP. So to differentiate PSP from MSA, we'll look at the autonomic dysfunction as well as the gaze pulse. This patient has several features of Alzheimer's disease, including short-term memory loss, episodes of disorientation with respect to place and disordered sleep pattern. The MMS score is supportive of the diagnosis. MRI with or without additional single photon emission CT is the gold standard approach to diagnosing the condition. Acetylcholinesterase inhibitor are the mainstay of the therapy. So depression, they in some cases they may also come with the features of pseudo dementia, but they will always have the mood disturbance associated with the sleep disturbance. Lewy body dementia will have the visual hallucination. Multi-infant dementia will have the or will always have the vascular risk factor, and NPH will comes up with the triad of DUG.
What is the most appropriate management of this patient? Gastric radiotherapy, H. pylori radiation therapy, imatinib, rituximab chemotherapy, and surgical resection. A 53-year-old man present to the gastroenterology clinic for the result of his upper GI endoscopy and biopsy following symptom of indigestion and small volume hematemesis. The biopsy shows evidence of gastric maltoma and he is Helicobacter pylori positive. So what is the most appropriate management?
So
H.
most
pylori eradication.
appropriate management in H. pylori positive gastric maltoma. So what should be the most appropriate management?
H. pylori eradication therapy.
Yes, we'll be going for the H. pylori eradication therapy, and usually we start with the triple therapy regimen. So what are the drugs that are included in the triple therapy? PAC or PMC? Either we'll
Yeah.
be going for the PAC regimen or we will be going for the PMC regimen. So we'll be going for PPI plus amoxicillin plus either clarithromycin or metronidazole. So P for PPI, A for amoxicillin plus either clarithromycin, or we can go for combination of PPI plus amoxicillin plus metronidazole. So in case of gastric malt lymphoma, the immediate next step would be eradicate H. pylori. H. pylori eradication therapy starting with the triple therapy, and if the patient does not respond to triple therapy, we can go for the quadruple therapy. And if the patient is unresponsive to both triple therapy and quadruple therapy, what should be the next step? We usually go for a two drug regimen in case of gastric maltoma. If there is no response to triple or quadruple therapy, whose two drugs are used? We usually go with the IR regimen, combination of imatinib and the rituximab. So if the patient with malt lymphoma does not respond to H. pylori eradication therapy, next step would be the combination of imatinib plus rituximab. And if the patient does not respond to this IR regimen, what should be the next step, or what should be the last resort? We will be going for the gastric radiotherapy. So we'll be starting with eradication with the triple therapy followed by quadruple therapy. No response, go for IR regimen. Imatinib plus rituximab. No response to IR regimen, go for the gastric radiotherapy. So what is the mode of action of imatinib and indication of imatinib?
Tyrosine kinase inhibitor.
Yes, this is the tyrosine kinase inhibitor. So tyrosine kinase
CML.
inhibitor, they are most commonly used in the management of CML,
CML.
chronic myeloid leukemia. So this is step 1. Combination of IR regimen is step 2, and last resort is the gastric radiotherapy. In some cases, you can also go for the surgical resection, but this is less commonly used. H. pylori eradication therapy is the intervention of choice for patient diagnosed with the gastric maltoma, even if they are H. pylori negative at the point of diagnosis. Studies suggest it promotes resolution in up to 80% of cases of gastric maltoma with the early disease. A course of PPI combined with 2 antibiotics from a choice of 3, clarithromycin or amoxicillin or metronidazole, is the usual regimen. Gastric radiotherapy is the intervention of choice for gastric maltoma where there has been an inadequate response to H. pylori within the rituximab based chemotherapy regimen. And this rituximab and imatinib, these two combination, they are usually used following the unresponsiveness to the eradication therapy. And in our original scenario, they also give the scenario of the low grade gastric maltoma, and they asked what should be the next step, and they have given two options. One was the biopsy, and the one was the H. pylori eradication. So most of the candidate get confused whether to go for biopsy or H. pylori eradication. So whenever you find gastric maltoma, whether this is H. pylori positive or H. pylori negative, the immediate next step would be H. pylori eradication.
What is the most appropriate next investigation? 24-hour 5-hydroxy indole acetic acid, 24-hour urinary free cortisol, glucose tolerance test, growth hormone random sample, and serum insulin like growth factor 1. A 45-year-old woman is referred to the endocrinology clinic with hypertension and impaired glucose tolerance. She also complains of excessive snoring and says she can no longer wear her ring due to the swollen finger. Her blood pressure is 155 by 92 millimeter mercury and BMI is 23 kg per meter square. She has macroglossia. So what is the most useful next investigation?
So most likely diagnosis.
Acromegaly.
Yes, so most likely this is the acromegaly. So what would be the most useful next investigation?
Next should be the IGF-1.
Yes, so we'll be going for the IGF-1. So the initial screening test or initial investigation of choice when we suspect acromegaly, we'll be going for the IGF, insulin-like growth factor, and it will be typically elevated. So for confirmation of diagnosis of acromegaly, we'll be going for the OCT2 with the growth hormone measurement. If the growth hormone fails to suppress below 1 milligram per deciliter, then the diagnosis of acromegaly is confirmed. So this OCT2 with growth hormone measurement, this is also known as the growth hormone suppression test. Remember, OCT2 with growth hormone measurement, the alternative name is the growth hormone suppression test. So this is for the confirmatory diagnosis, and initial or first line investigation would be the acromegaly. And after confirmation of the next step, we'll be going for the pituitary MRI. Pituitary MRI would be the next logical step to decide for the treatment purpose. And lanreotide is the first line choice of treatment. Transsphenoidal surgery, this is the definitive choice of treatment. In past medicine, transsphenoidal surgery, this is given as initial treatment of choice, but more appropriate is that initial intervention of choice would be lanreotide. Specific or definitive management would be transsphenoidal surgery, and octreotide is the adjunctive treatment. So don't get confused. This is lanreotide is the first line choice of treatment. Octreotide is the adjunctive treatment. Transsphenoidal surgery, this is the definitive treatment, or this is the specific treatment. So we'll be going for the serum IGF-1 as the most useful next investigation. And for confirmation, we'll go for OCT2 with growth hormone measurement, also known as the growth hormone suppression test. And 24-hour urinary free cortisol, this is the screening test for which condition?
It's for the no,
Yes, this is for the
carcinoid
Cushing
syndrome.
syndrome. And 24-hour 5-hydroxyindole acetic acid.
Hydroxy is
This is
Carcinoid
for,
syndrome.
carcinoid
yes,
syndrome.
this is for the
Yeah.
carcinoid syndrome. So for this is the initial investigation for carcinoid syndrome, 24-hour urinary hydroxyindole acetic acid. For Cushing syndrome, 24-hour urinary free cortisol. For pheochromocytoma, 24-hour urinary catecholamine or 24-hour urinary metanephrine. So if both of them are in the option, what would be the answer? Catecholamine or metanephrine? You'll be going for the metanephrine. Metanephrine is more appropriate. And in case of celiac disease, you will be going for the anti-TTG antibody. IGF-1 is produced by the liver, and its concentration parallels that of growth hormone in contrast to the growth hormone. However, IGF-1 has a long half-life, which makes it appropriate to measure as a random outpatient sample. It is therefore the initial investigation of choice for this patient who has hypertension, impaired glucose tolerance, microglossia, peripheral edema, and a normal BMI, all of which fits with the acromegaly. And 24-hour HIA in case of carcinoid syndrome, 24-hour urinary free cortisol in case of Cushing syndrome. And in the original recall, they gave the scenario of the acromegaly, and they directly asked regarding the confirmatory test. So the confirmatory test would be OCTT, glucose tolerance with the growth hormone measurement.
So what is the most likely cause of the patient's symptoms? Bacillus cereus, norovirus, Salmonella typhi, Shigella sonnei, and the Staphylococcus aureus. 3 individuals from the same family, aged 54, 22, and 21 years, present to the emergency department. They have been having projectile vomiting for the past hours. A meal of fried rice from the Chinese takeaway was eaten 4 hours earlier. So what is the most likely cause of the patient's symptoms?
Also, whenever you encounter the infective diarrhea, always the step one would be to look at the incubation period. So the incubation period here is shorter, less than 6 hours. So what are the differential diagnoses having the short incubation period?
Bacillus cereus,
Yes,
Staph
one is
aureus,
the Bacillus cereus and another one is the Staphylococcus aureus. So how can we differentiate whether this is aureus or this is Bacillus cereus?
In case of aureus, there will be vomiting predominant.
Yes,
And
patient
in
will
case
have
of
the predominant vomiting. In case of Staphylococcus aureus, which is related to the preform toxin, and this is usually related to the buffet display of food, especially the making up from the milk or the creamy products. And in case of Bacillus cereus, the cardinal feature would be the reheated fried rice or the Chinese takeaway meals. So Chinese takeaway, this is one of the clues in favor of the Bacillus cereus. And projectile vomiting. So projectile vomiting, it may occur in case of Bacillus cereus, but projectile vomiting is more commonly seen in case of Staph aureus
norovirus.
as well as the norovirus. So norovirus, this is the commonest cause of gastroenteritis, and patient will come up with the features of projectile vomiting, explosive diarrhea, and it will come up in an epidemic form. But here, since there is a very short incubation period, so we are going for the Bacillus cereus instead of the norovirus. Norovirus usually occurs in a closed environment like in a cruise ship or in a closed building, and Bacillus cereus, this is related to the Chinese takeaway due to the reheated fried rice. Salmonella typhi and the Shigella, they will come up with the bloody diarrhea. They will usually have the incubation period about 36 to 72 hours. And Staph aureus, it will also come up with the short incubation period. Patient may have the projectile vomiting, but this is related to the dairy product, or this is related to the buffet display product. This is not related to the Chinese takeaway meal. Bacillus cereus is known as a contaminated fried rice, particularly if this is reheated after it has been left standing for a prolonged period. According to the subtype of the bacterium, either the emetic toxin, the cerulite, or a diarrheal toxin can be produced. Symptoms generally begin within 1 to 6 hours of ingestion of the contaminated rice and resolve without intervention 6 to 24 hours of ingestion. And norovirus will have projectile vomiting, explosive diarrhea in a closed environment in an epidemic form. And Staph aureus, this is related to dairy product, and patient will have the vomiting a few hours after the ingestion, and this is either related to cream based dessert in a wedding party, but wedding party usually always consists of the meat products. So wedding party, this is also related to the Campylobacter jejuni infection. And in our original recall, or in the original exam, this question was a little bit more complicated. So in the scenario, the patient presented after 24 hours with the vomiting and abdominal pain, and there was history of taking the meat products in a restaurant previously with the 7 friends, and out of the 7 friends, most probably 2 or 3 friends had the symptoms after 2 to 3 hours of the meal. So since it had the short incubation period after 2 to 3 hours, and there's history of taking in restaurants, they didn't exactly mention whether they take uh, uh, the fried rice or some other. They just give a clue of the restaurant, and out of the 7 friend, 2 or 3 friends had the similar symptoms, and it was very confusing whether to go for the norovirus or bacillus cereus. So since out of 7 friends, 2 or 3 friends was affected, so bacillus cereus was a more appropriate answer. Next.
What is the most appropriate intervention? High dose prednisolone and itraconazole, high dose prednisolone, low dose prednisolone, omalizumab, roflumilast. A 47-year-old woman is referred to the respiratory clinic for asthma control. She is currently taking fluticasone 500 microgram twice daily, salmeterol 50 milligram twice daily, and montelukast. Despite this, she has required 4 courses of oral prednisolone in the past year. Her peak expiratory flow rate is 350 liters per minute. Hemoglobin is low, 115 gram per liter. WBC is high, 12.3 into 10 to the power 9 liter, and the eosinophil level is high also. Chest X-ray, the lung, clear lung field. So what is the most appropriate intervention?
So what should be the most appropriate intervention in this patient?
Only
Omalizumab.
eosinophil count is high, so it should be the omalizumab. Yeah.
So features of worsening asthma plus eosinophilia will be going for the omalizumab, and features of asthma plus elevated IgE level, what should be the treatment?
Mepolizumab.
Yes, we'll be going for the mepolizumab. So these two are very important, especially for part 1. So severe asthma with
So no,
elevated.
it's yeah, it's just the reverse actually.
Yeah,
Yeah.
this
So
is
where there
the
is IgE elevated,
reverse.
there will be omalizumab. It should be the mepolizumab. There is no option here actually.
Okay, yeah. So let's go one by one. So severe asthma with elevated eosinophil, we will be going for the mepolizumab, and mepolizumab is the anti-interleukin 5 monoclonal antibody. And in case of elevated IgE, we'll be going for the omalizumab. Omalizumab is the anti-IgE antibody. So if IgE level is elevated, we go for omalizumab. If eosinophil level is elevated, we'll be going for the mepolizumab. So if we go one by one, so high dose prednisolone and itraconazole, this is indicated in which condition?
In case of ABPA,
Yes, this is indicated in case of ABPA. Usually the initial choice of treatment is the prednisolone followed by itraconazole, or in severe cases we can go with the combination of both prednisolone and itraconazole. So ABPA usually comes up with the features of worsening asthma plus eosinophilia. So asthma plus elevated eosinophil count, it has the 2 typical differential diagnoses. One is the CSS, another one is the ABPA. CSS, this is one of the vasculitic condition. So they will have the multisystemic involvement, especially they will comes up with the mononeuritis multiplex or with the features of renal involvement. And in case of ABPA, the features are exclusively related to the respiratory system. So can it be a case of ABPA? Yes or no?
can be actually, but there are
So
no other
what should
feature
be
actually
the
present.
radiological findings in case of ABPA? Radiological findings. ABPA radiological findings.
Proximal dilatation.
Yeah, proximal bronchiectasis.
There will be features of proximal or central bronchiectasis, or there will be features of patchy shadowing. In the initial periods, there should be patchy shadowing, and in the advanced cases, we'll get the features of central or proximal bronchiectasis. So here, the chest X-ray is normal, so this is making the ABPA unlikely. And if we consider the high dose prednisolone, this is given in case of EGPA, but the patient does not have the features of vasculitis or mononeuritis multiplex, so CSS is also less likely. And roflumilast, what is the mode of action of roflumilast?
Phosphodiesterase 4 inhibitor.
Yes, this is the phosphodiesterase 4 inhibitor. And indication of roflumilast?
COPD when the conventional drug fails.
COPD patient not responding to triple inhale therapy. After giving triple inhale therapy, if the patient does not if a patient with COPD does not respond, you'll be going for the roflumilast, and roflumilast is the phosphodiesterase 4 inhibitor. There is another phosphodiesterase 4 inhibitor known as the apremilast. Apremilast, what is the mode of action of apremilast?
Same phosphodiesterase 4 inhibitor.
No,
Mode
no.
of action.
Sorry. What should be the indication of apremilast? Yes, this is
Psoriasis.
indicated in case of psoriasis. So also the roflumilast should be less likely. So this question is actually confusing. Here it should be the mepolizumab. By mistake, they have given the omalizumab. So actually, the choice of intervention, most appropriate intervention in this patient would be the mepolizumab. So it should be actually the mepolizumab, and high dose prednisolone itraconazole in case of ABPA. So what is the first line choice in case of ABPA? Itraconazole or steroid?
Steroid first
Yes.
line.
Always remember, steroid is the first line. So there are many candidates, they often make this mistake. They go for the itraconazole as the first line. Always remember, in case of ABPA, steroid is the first line, itraconazole is the second line. And this roflumilast, this is the phosphodiesterase 4 inhibitor. This is indicated in COPD if the patient does not respond to triple inhale therapy. And in our original scenario, they give you the history of the long-standing worsening asthma with features of eosinophilia, and they clearly mentioned the patient developed vasculitis after initiating the Montelukast. So diagnosis: developing vasculitis following
Gerstrom
leukotriene
syndrome,
receptor
EGPA.
antagonist is the CSS, also known as the EGPA. Patient with EGPA, they will have the worsening features following exposure to Montelukast or leukotriene receptor antagonist. So whenever patient with asthma, the features worsens or patient comes up with the features of vasculitis after giving Montelukast, this is CSS, also known as the EGPA.
What is the most likely cause of the patient's symptoms? Cerebral venous thrombosis, herpes simplex encephalitis, ischemic stroke, subarachnoid hemorrhage, and subdural hematoma. A 28-year-old woman is brought to the emergency department with severe headache, double vision, and loss of sense of smell. According to her husband, she has been increasingly drowsy and confused over the past 48 hours. A previous DVT led to the identification that she is heterozygous for the factor V latent. Her temperature is 37.8 degrees Celsius and blood pressure is 165/88 millimeter mercury. She has bilateral optic disc swelling and unable to comply with the basic commands. So what is the most likely cause?
So most likely diagnosis or most likely cause of this patient's symptoms?
Factor V latent. So should be something thrombosis.
So this is our CVST, cerebral venous sinus thrombosis.
رجعي كوباية رجعي الكوباية دي عليه لا ما تجيبي دي رجعي الكوباية دي في مكانها امشي عليه رجعي الكوباية في مكانها
So this usually occurs in a young obese female, often with a history of the factor V laden heterozygosity. And a patient usually comes up with the acute onset of sudden severe unremitting dull headache. In some cases, the chronic symptoms may also occur, especially if the patient comes after a few months. Usually worsen when lies flat, strain when using the toilet, with history of sudden worsening headache. And there will be features of bilateral sixth nerve palsy. In some cases, there may be involvement of the first cranial nerve, coming up with the features of anosmia. There will be features of papilloedema and the hypertension. Diagnosis is the CVST. Investigation of choice should be MR venogram with or without lumbar puncture and the pressure measurement. And management would be anticoagulation with the low molecular weight heparin. So this is our CVST. What should be the presentation in case of herpes simplex encephalitis? Cardinal radiological features.
Temporal lobe.
Yes, there would be temporal lobe changes either in the CT scan or MRI. So there would be either MRI or CT changes in the temporal lobe, and if you go for MRI, there will be hyperintense lesion in the temporal lobe. There may be surrounding vasogenic edema. On the if you go for CSF, there will be features of lymphocytosis with elevated CSF protein. They usually comes up with the gradual decrease in consciousness, short-term memory loss, and the gait disturbance. And in some cases, they will give history of business trip to Tokyo. And investigation of choice would be lumbar puncture with PCR, and choice of treatment should be IV acyclovir. What is the mode of action of acyclovir?
DNA polymerase inhibitor.
Yes, this is the DNA polymerase inhibitor. So this is less likely to be herpes simplex encephalitis. Ischemic stroke, they will come up with the sudden deterioration with the focal neurological deficit. Here there is a gradual worsening of the symptoms with headache and papilloedema. So this is more sensitive of the venous thrombosis, especially presenting with papilloedema, as well as the factor V laden heterozygosity. Subarachnoid hemorrhage, they usually comes up with the thunderclap headache, worst headache in their life, usually involving the occipital zone. They will also comes up with the acute presentation. Subdural hematoma, this is more commonly seen in the elderly patient. There will be history of chronic alcoholism. The typical features would be history of frequent fall, and they will come up with the features of fluctuating consciousness. This patient has had a gradual deterioration over a few days with the evidence of cranial nerve palsy, loss of sense of smell, raised ICP, increased risk of venous thrombosis. This raises the possibility of the underlying CVST, for which the MR venography is the investigation of choice. Anticoagulation with the low molecular weight heparin, this is the intervention of choice. And the herpes simplex, they will have the temporal lobe changes. Ischemic stroke, they will come up with the features of FND. Subarachnoid hemorrhage, they will come up with the thunderclap headache. And subdural hematoma, this is usually found in the elderly patient.
What is the best way to evaluate the risk of the heart failure versus baseline characteristics? The multivariable modeling with the background elimination, retrospective cohort study, sensitivity analysis, and univariable modeling. A cardiovascular outcome trial is reported for roxagliptin, a new diabetic therapy added to standard of care versus standard of care alone. A total of 3.5% of patients given the drug were hospitalized for heart failure versus 2.8% for those treated with the standard of care alone. The risk appeared to be increased in the patient with the baseline renal impairment. So the best way to evaluate the risk of heart failure versus the baseline characteristics, what is?
So evaluation of the heart failure versus the baseline characteristics. So you need to, this is a new concept and there's nothing to understand. You just need to memorize. Multivariable, you'll be going for the multivariable. For determination or the best way for evaluation of a risk of heart failure against the baseline characteristic, we'll be going for the multivariable modeling with the background elimination. Multivariable modeling with the background elimination. Multivariable modeling with background elimination is the optimal way to determine which baseline characteristics contribute to the risk of the heart failure. A constellation of risk factors are identified, and background elimination then removes those who contribute least to an increased risk. This analysis is what was deployed in the saxagliptin study referenced here. Sensitivity analysis is used to determine whether a subgroup analysis reveals a significantly different result versus the whole trial population. It does not estimate the most important baseline risk factor contributing to the heart failure.
What is the most likely cause of the patient's symptoms? Abducens nerve palsy, cerebellar stroke, internuclear ophthalmoplegia, oculomotor nerve palsy, optic neuritis. A 59-year-old man present to the emergency department complaining of recent onset double vision. He has type 2 diabetes and takes metformin and dapagliflozin. He has horizontal diplopia with the failure to adduct the left eye, and there is a nystagmus affecting the right eye. So what is the cause? Internuclear ophthalmoplegia.
So the most likely diagnosis here is the INO, internuclear ophthalmoplegia, and this this is usually characterized by failure of adduction. Remember, this is adduction, double D. Failure of adduction of the ipsilateral eye, and there would be nystagmus in the contralateral eye, and this usually occurs due to damage in the MLF, medial longitudinal fasciculus, which is a neural pathway that coordinates the eye movements between the oculomotor and the abducens nerve. So there will be failure of adduction in the ipsilateral eye, and there would be nystagmus in the contralateral. So nystagmus is always contralateral. Remember this. In case of ENO, in case of MLF, the nystagmus is always contralateral. The adduction, ADD, this is always unilateral. So if this is the right MLF, there would be conjugate gaze palsy with diplopia looking to the opposite side. So patient will have impaired adduction on the ipsilateral eye, horizontal nystagmus of the contralateral eye, and this is due to a lesion in the MLF, median longitudinal fasciculus. And this MLF lesion, this is situated in the paramedian areas of the brainstem, in between the pons and the medulla. So the key features would be failure of adduction of the ipsilateral eye. So here there is failure of adduction of the left eye, indicating left-sided internuclear ophthalmoplegia. There will be nystagmus of the opposite eye as a result of the compensatory response seen in an unaffected eye. And usually the this is more commonly associated with the diabetes mellitus, especially with the long-standing diabetic mellitus or with the poorly controlled cases. They have a higher chance of developing the vessel disease, which usually affects the MLF, leading to the And with respect to the other options, so abducens nerve palsy, so this is it will lead to paralysis of the lateral rectus muscle. So there would be inability to abduction. So ABD. So if abducens nerve is paralyzed, there would be inability of abduction. And if in case of there would be inability or failure of adduction. So adduction in case of and in case of abduction, in case of abducens nerve, there would be abduction. Patient with cerebellar stroke, they may also comes up with the features of nystagmus, but there will be some other associated features, especially the ataxia and other coordination issues like the unstable gait and the eye movement abnormalities. The isolated eye movement abnormalities, they are usually rare in case of cerebellar stroke. And the oculomotor nerve palsy. So this oculomotor nerve palsy, they usually comes up with the multiple eye movement issues like the features of ptosis, papillary dysfunction, and also there will be inability to adduct, elevate, and the depressed eye. So in case of oculomotor nerve palsy, the affected eye would be down and out. So one of my friend, he used to remember the oculomotor nerve palsy as an ejaculatory phenomenon. So the affected eye would be down and out in case of oculomotor nerve palsy. And optic neuritis. So optic neuritis, they will usually comes with the features of visual loss or with the loss of the color vision. There may be loss of visual acuity, and this is usually associated with the pain. This is also not related to the eye movement dysfunction or diplopia. And also there will be features of relative afferent pupillary defect, RAPD, in a patient with optic neuritis. And optic neuritis, this is usually most commonly seen in a patient with multiple sclerosis. Internuclear ophthalmoplegia fits with the symptoms here, where there is failure of adduction of the eye on the affected side, nystagmus of the contralateral eye. This is consistent with injury to the medial longitudinal fasciculus, which can occur as a result of small vessel stroke related to diabetes mellitus and inflammatory conditions such as the multiple sclerosis. In case of abducent nerve palsy, there will be failure of abduction and cerebellar stroke along with the nystagmus. There will be associated ataxia or unstable gait. And oculomotor nerve palsy, remember, as an ejaculatory phenomenon. And optic neuritis with the features of RAPD or with the features of loss of color vision or visual loss or reduction in the visual acuity.
Which of the following autoantibody is most likely to be positive in this patient? Anticyclic citrullinated peptide, anti-CCP, anti-LA, anti-mitochondrial, anti-nuclear, anti-smooth muscle. A 38-year-old woman is referred to the rheumatology clinic with the photosensitivity rash and multiple small joint polyarthritis. She has also suffered from night sweat and gradual weight loss over the past few months. So what is the following autoantibody is mostly likely to be the positive?
So most likely diagnosis.
ANA is SLE.
Yes, most likely this is a case of SLE, and in case of SLE, the gateway or the most likely or most sensitive one is the anti-nuclear antibody ANA. So this is the gateway. This is the initial antibody investigation of choice when SLE is suspected. Anti-CCP. So anti-CCP, this is it should be found positive in a patient with rheumatoid arthritis, and this is associated with the poor prognosis as well as the aggressive joint destruction. Anti-La is also known as anti-SSP, and anti-Ro is known as anti-SSA. So anti-Ro and anti-La, they are related to the neonatal congenital heart block. So if you compare anti-Ro with anti-La, which one is more commonly related to neonatal heart block?
Anti-Ro.
Yes, anti-Ro is more commonly related to neonatal heart block. And anti-mitochondrial in which condition?
In case of PVC.
Yes, in case of primary biliary cirrhosis or cholangitis. And in asthma, anti-smooth muscle.
In autoimmune hepatitis.
Yes, in case of autoimmune hepatitis. And other antibodies that may be found positive in case of autoimmune hepatitis.
In type 1, that will be asthma, anion asthma. In type 2 is LKM1. And in type 3 is soluble
liver kidney antigen. So how to treat a case of autoimmune hepatitis? Treatment. How to treat a case of autoimmune hepatitis? First line choice of treatment.
Oral steroids.
Yes, we'll be going for the
steroid.
steroid. We'll be going for the steroid therapy in case of autoimmune hepatitis. These patient symptoms are typical of SLE with a photosensitive rash and small joint polyarthritis. 95% or more of the patient with lupus are positive for anti-nuclear antibodies. Other antibodies such as Rho and La may be found but are not characteristic. So anti-CGP, rheumatoid arthritis, anti-La, neonatal congenital heart block, Sjogren's syndrome. AMA in case of PBC, it would be PBC, primary biliary, not PSC. Asthma in case of autoimmune hepatitis.
What is the most likely cause of the patient's symptoms? Behçet's disease, celiac disease, Crohn's disease, topical sprue, and the last one, and the Whipple's disease. Okay. So a 45-year-old man is referred to the gastroenterology clinic with diarrhea, weight loss, and multiple joint pains. A biopsy shows villus atrophy with the periodic acid shift past positive macrophages. So Whipple's disease.
Also, features of malabsorption plus arthralgia plus villus atrophy plus the past positive macrophage. So this past positive macrophage, this is the pathognomonic features of the Whipple's disease.
Okay.
So which organism is responsible for the Whipple's disease?
Toparama Whipple.
Yes, Tropoerema Whipple. So how to treat a case of Whipple's disease? Antibiotics of choice?
Ceftriaxone for 1 to 2 weeks, and for 1 year. That will be the cotrimoxazole.
Yes, we'll be going for IV ceftriaxone for 1 to 2 weeks, followed by oral cotrimoxazole. Usually, typical regimen is up to 1 year. In some patient may need up to 2 years. So IV ceftriaxone for 1 to 2 weeks, followed by oral cotrimoxazole for 1 year or 1 to 2 year. And in case of Behçet's disease, this is usually more commonly seen in the Mediterranean patient, and they will come up with the triad of oculo-oral genital manifestation. There may also be features of shin lesion or with the features of deep vein thrombosis. Which HLA is related to Behçet's?
HLA-B51.
Yes, HLA-B51. And how to treat a case of Behçet's disease?
Steroid.
Yes, we'll be starting with the prednisolone. If there is no response, you can go for the steroid sparing azathioprine. So patient with celiac disease, they may also come up with the features of malabsorption, but they are usually associated with the dermatitis herpetiformis. And in case of dermatitis herpetiformis, there would be itchy rash affecting the buttocks and the posterior thigh. And in case of Crohn's disease, so if we go for the biopsy, in case of Crohn's disease, there would be predominantly lymphocytic infiltration. And topical sprue, patient with topical sprue, they will come up with the features of chronic diarrhea plus weight loss. So they will exclusively only have the exclusive GIT manifestation. There won't be any multisystemic involvement. But in case of Whipple's disease, there would be multisystemic involvement and past positive macrophage. This is the pathognomonic features. And for the management of tropical sprue, T for tropical, T for the tetracycline. Usually we go for the tetracycline based regimen, usually 3 to 6 months. And we also need to go for the vitamin B12 and the folate supplementation. Whipple's disease presents with the features of malabsorption and arthritis and small bowel infiltration with the past positive macrophage is the typical of the condition. The macrophage contain intracellular clumps of Tropoerema whipple. The causative organism prolonged antibiotic treatment is required, usually with a course of IV ceftriaxone for 2 to 4 weeks. Usually we go for 1 to 2 weeks, followed by oral cotrimoxazole for 1 to 2 years. So Behçet's will have oculo-oral genital manifestations. Celiac disease will have associated DH. And in case of Crohn's disease, there would be lymphocytic infiltration. And tropical sprue, they will have the exclusive GIT manifestation.
What is the patient's strongest risk factor for successful suicide? A 21-year, okay, options is age 21, alcohol use disorder, employment as a nursery nurse, number of tablet taken, and previous self-harm. 21-year-old woman who works at a nursery is brought to the emergency department following a paracetamol overdose. She had taken 50 into 500 milligram tablets and left a note to her parents. Her boyfriend found her and called for an ambulance. She has self-harm marks in the both wrist. She had a previous paracetamol overdose 4 years ago and was admitted to the emergency department with the intoxication for 3 previous occasions. So what is the patient's strongest risk factor for successful suicide?
So which one is the strongest risk factor for successful suicide?
Previous self-harm.
Yes, this is the previous self. A number of meta-analyses have attempted to rate the risk of suicide mortality according to the characteristics of each case. One such meta-analysis is referenced here. A pooled odds ratio estimate of 10.1 is described for patients who have previous episodes of self-harm. Although some of the other risk factors listed here, such as alcohol use disorder, also impact risk, they are considered less contributors. So previous self-harm 10.1. Usually the elderly patient, they are more susceptible to the suicidal risk. Alcohol use is 3.2.
What is the most useful investigation? Basophil count, eosinophil count, muscle tryptase, prolactin, and total immunoglobulin E. A 23-year-old woman present to the emergency department with the eye and throat itching, a hives-like rash, and shortness of breath after taking her second dose of amoxicillin. She is treated with intramuscular adrenaline, which resolves her symptoms. So what is the most useful investigation?
So diagnosis.
Anaphylaxis.
Anaphylaxis.
Yes,
Yeah.
this is the
Anaphy-
anaphylactic reaction. So in case of anaphylaxis or anaphylactic reaction, what should be the most useful investigation?
Muscle tryptase.
So we'll be going for the mast cell tryptase. So in case of anaphylactic reaction, there will be a massive muscle degranulation, and this massive muscle degranulation, this usually leads to the increased release of mast cell tryptase. So we'll be going for the mast cell tryptase as an investigation. Mast cell tryptase increases with mast cell degranulation and is a key feature of anaphylaxis. The most likely diagnosis here, given the exposure to amoxicillin, levels peak within 30 to 90 minutes after the onset of symptoms. The reference range is 2 to 14 microgram per liter, and checking out trough level 24 hours after the episode is useful. Treatment of anaphylaxis include intramuscular adrenaline as the mainstay of the therapy. Also in the original recall, this question was pretty straightforward. They give the scenario of an anaphylactic reaction with the features of hypotension, and they directly ask what should be the next step in management. So next step in management would be the intramuscular adrenaline.
What is the most appropriate intervention? Atomoxetine, midodrine, modafinil. I cannot see the lower portion.
Okay, this is lagging. Okay, you can read from the top.
Okay, so a 69-year-old man who has advanced Parkinson's disease is reviewed by the GP. His current medication includes careldopa, entacapone, and ropinirole. His motor symptoms are well controlled, although when his medications are reduced, he experiences disabling of symptoms. His main complaints is of multiple syncopal episodes when he gets up from the chair after meals or gets up too quickly in the morning. He has tried TED stockings with a minor improvement. His lying blood pressure is 142 by 80 millimeter mercury, and which falls to 105 over 65 millimeter mercury on standing. So there is a postural drop. So what is the most appropriate intervention?
So diagnosis,
Parkinson's disease with the
advanced
postural
Parkinson's
drop.
disease plus features of postural hypertension, meaning there is autonomic dysfunction. So PD plus autonomic dysfunction is the MSA, multi-system atrophy.
Atrophy.
Uh, so how to treat a case of postural hypertension in a patient with MSA? Step 1 management. Step 1 would be the non-pharmacological measures like the TED stalking, but there is unresponsiveness to the non-pharmacological therapy. So next step would be the pharmacological therapy. So which drugs can be used in the management of postural hypotension?
Midodrine.
Yes, we can go for the midodrine. What is the mode of action of midodrine? What is the
Peripheral
mode of...
vasoconstrictor.
So for the management of postural hypertension in a patient with multi-system atrophy, we will be going for the midodrine. And this midodrine, this is the alpha-1 adrenergic receptor agonist. This is alpha-1 receptor agonist. So atomoxetine, what is the mode of action of atomoxetine?
Is that right?
This is the noradrenaline reuptake transporter inhibitors. And what is the mode of action of modafinil? This is noradrenaline reuptake inhibitor. This is dopamine reuptake inhibitor. And both atomoxetine, modafinil, both of them are used in the management of attention deficit hyperactive disorder. And reserpine has the reverse action in compared to the midodrine. Midodrine is the alpha-1 adrenergic receptor agonist, and reserpine is the alpha-1 adrenergic receptor antagonist or blocker. So this reserpine, this is contraindicated in a patient with orthostatic hypotension. And risperidone, this is the atypical antipsychotics, and this is more commonly indicated in a patient with acute schizophrenia. So midodrine, this is an alpha-1 adrenergic agonist. This is considered as the first-line intervention for patient with postural hypotension despite the non-pharmacological measures such as the TED stalking. Dosing is 2.5 to 10 milligram given up to 3 times daily. Supine hypertension and urinary retention, they are the adverse effects of the concern. And atomoxetine, this is noradrenaline reuptake inhibitor. Modafinil is the dopamine reuptake inhibitor. Both of them are used in the treatment of ADHD. Reserpine, this is reverse action of the midodrine. And risperidone, this is the atypical antipsychotics.
What is the most appropriate intervention? Altiplase, clopidogrel, dalteparin, ticagrelor, unfractionated heparin. 25-year-old woman is brought to the emergency department following a collapse at the airport after returning from the holiday to Kenya. She is complaining of left-sided pleuritic chest pain and has a swollen left leg. The blood pressure is 85 by 50 millimeter mercury, and heart rate is 105 beats per minute and regular. Her chest is clear on auscultation, and the respiratory rate is 38 beats per minute. The oxygen saturation on air is 91%. ECG and echo reveals right ventricular strain. So what is the most appropriate intervention?
So most likely diagnosis.
Massive pulmonary embolism.
Yes,
Yeah,
this is the
following.
massive pulmonary embolism. And patient has the features of hypotension pointing towards the hemodynamic compromisation. So PE plus hypotension, intervention of choice.
Thrombolysis.
Yes, we'll be going for the thrombolysis with the altiplase. And clopidogrel, ticagrelor, they are the antiplatelet drugs. So mode of action of clopidogrel and ticagrelor,
PY12P inhibitors.
Yeah,
they are the
ADP inhibitor.
PY12 inhibitor, also known as the ADP receptor blockers. And this dalteparin is the low molecular weight heparin. This is indicated in a patient with pulmonary embolism having the hemodynamic instability. But whenever there is hypotension, directly go for the thrombolysis. This patient has a large pulmonary embolism with hemodynamic instability and evidence of right ventricular strain. She is at imminent risk of cardiorespiratory arrest, and thrombolysis is the only appropriate option. The recommended dose for pulmonary embolism is 0.9 milligram per kg delivered over a period of 60 minutes.
What is the most appropriate first-line intervention? Carbamazepine, gabapentin, ibuprofen, oxygen therapy, and sumatriptan. 35-year-old woman is referred to the neurology clinic with the episodes of sudden, sharp, stabbing pain over the left cheek. The pain can last from few seconds up to 30 seconds in duration and may occur many times per day. She says the pain can be triggered by cleaning her teeth or going out in the cold weather. Neurological examination is unremarkable. So first-line intervention. Carbamazepine.
So diagnosis. This is
Trigeminal neuralgia.
trigeminal neuralgia. And for the management of trigeminal neuralgia, first-line intervention is the carbamazepine. What is the mode of action of carbamazepine?
Sodium channel blocker.
Yes, this is the voltage-gated sodium channel inhibitor or sodium channel blockers. And apart from carbamazepine, the gabapentin and pregabalin, these two drugs can be used as an adjunctive therapy, but this is not the first line treatment, or this is not the most appropriate treatment. They are just the adjunctive treatment. And if a patient with trigeminal neuralgia, they have if there is failure on pharmacological therapy, then what should be the next step? We'll be going for the surgical option, trigeminal nerve decompression surgery. If there is failure to pharmacological therapy, we'll be going for the trigeminal nerve decompression surgery. And oxygen therapy, especially 100% oxygen therapy. This is the first line for the management of acute cluster headache. And the triptans or sumatriptan, they are usually used for the acute management in case of migraine or in a patient with cluster headache who fails to respond to the oxygen therapy. So we'll be going for the carbamazepine. This patient has symptoms that are typical of trigeminal neuralgia, and the normal neurological findings in the clinic are in keeping with this diagnosis. Carbamazepine is understood to carry the best evidence for medical therapy, and the NICE recommends treatment until patients have had no episodes for 1 month, then attended to wane of the treatment. Gabapentin and pregabalin are also thought to be effective. So this gabapentin, pregabalin, they are for the adjunctive management. And if there is no response to pharmacological therapy, we'll be going for the surgical trigeminal nerve decompression procedure.
What is the most appropriate? What is the most important abnormality to treat at this stage? Hyperkalemia, hyperphosphatemia, hyperuricemia, hypotension, metabolic acidosis. A 23-year-old woman is reviewed on a hematology ward 48 hours after beginning induction chemotherapy for AML. A significant deterioration in her renal function has been noted. The blood pressure is 90 over 60 millimeter mercury. Hemoglobin is low, 87 gram per liter. WBC is very high, 21.2. Platelet is low, sodium normal, potassium is very high, 6.7. Bicarbonate is low, 17, phosphate 1.9, which is high, and the creatinine also high, is 395. So what is the most important abnormality to treat at this stage? Hyperkalemia?
So most likely diagnosis following the induction chemotherapy.
Tumor lysis syndrome.
This is the TLS, tumor lysis syndrome. So tumor lysis syndrome, they usually comes up with the long list of abnormalities, but which electrolyte abnormality is the most concerning? This is the hyperkalemia. How to treat a case of tumor lysis syndrome? Treatment.
Is Rasburicus hydration.
Hydration and then Rasburicus.
Yeah.
So in case of tumor lysis syndrome, patient will have hypocalcemia, low calcium, and usually all other things would be elevated, like elevated potassium, phosphate, uric acid, LDH, creatine, and the most concerning one is the hyperkalemia. So high uric acid, renal impairment following chemotherapy. This is the tumor lysis syndrome. And for the treatment, we'll be going for the Rasburicus. And for the prophylaxis, we can either go for allopurinol or we can go for Rasburicus. So allopurinol, this is only for the prophylaxis, prophylactic management. And Rasburicus can be given for prophylaxis. It can be given for an acute treatment. So the dose will differ. In case of treatment, we'll be going for the treatment dose or high dose Rasburicus, 200 microgram per kg. And for the prevention, for the prophylaxis, we'll be going for the prophylactic low dose Rasburicus, 3 microgram. So 3 microgram per kg in case of prophylaxis and 200 microgram per kg in case of treatment. So allopurinol is only for prophylaxis. And Rasburicus, this is both for prophylaxis as well as the acute treatment. Although this patient has tumor lysis syndrome as a result of hyperuricemia related to cell lysis, the most urgent problem which requires intervention is the hyperkalemia, which puts the patient at the risk of cardiac arrest. The patient should receive cardiac monitoring. In the first instance, a cardioprotective dose of calcium gluconate is given. This should be followed by adequately rehydration, correction of hypotension, insulin and dextrose to reduce the potassium concentration acutely, and treatment for the hyperuricemia. So most concerning one would be the management of hyperkalemia.
So, which of the following cancer is most likely to be cause of the patient's skin changes? The breast cancer, bronchial carcinoma, gastric carcinoma, medullary thyroid cancer, renal adenocarcinoma. A 58-year-old woman is referred to the oncology clinic with the anemia and weight loss of 3 kg over the past months. She has developed hyperpigmentation of the both axilla with the skin thickening and has a papillomatous lesions in the mouth. So hemoglobin level is low. So what is most likely to be cause of the patient's skin changes?
So hyperpigmentation of both axilla, skin thickening, papillomatous lesion in the mouth. So this condition points towards most likely this patient is having the acanthosis nigricans, and acanthosis nigricans is related to which cancer? Which cancer is related to acanthosis nigricans?
Gastric adenocarcinoma.
Gastric
Yes,
adenocarcinoma.
gastric adenocarcinoma. A for acanthosis, A for adenocarcinoma or gastric adenocarcinoma. So what are the other conditions that are associated with acanthosis nigricans other than
PCOS.
The metabolic diseases, the diabetes, the acromegaly, obesity, PCOS.
So A for acanthosis, A for the adenocarcinoma. The most common malignancy associated with acanthosis nigricans is the gastrointestinal adenocarcinoma. This is one of the skin condition characterized by symmetrical brown velvety flakes with dark thickened patches, often termed as hyperkeratosis and hyperpigmentation of the skin, predominantly affecting the flexural skin fold like the neck, axilla, and the groin. This is often associated with the insulin resistance and can be an early sign of type 2 diabetes. So most common association is the diabetes or insulin resistance, and most common malignant association is the gastric adenocarcinoma. So and alongside some other metabolic disease like obesity, PCOS, acromegaly, they can also be associated with the acanthosis nigricans. And erythema chiratum repens, this is associated with which condition?
Lung
Erythema
cancer.
chiratum repens, this is
There's a
related
lung
to which
carcinoma.
condition? This is related to the lung cancer, the bronchial carcinoma. Acanthosis nigricans is the most commonly associated with the syndromes of insulin resistance, obesity, type 2 diabetes. It has also been described in association with malignancy, most commonly gastric cancer, which could account for anemia and the weight loss seen here. An increase in transforming growth factor is thought to be responsible. In total, around 60% of malignant cases are thought to be due to the gastric cancer. So A for acanthosis, A for adenocarcinoma, gastric adenocarcinoma. So what is the mode of action of atorvastatin? What is the mode of action of atorvastatin?
3-hydroxy.
3-hydroxy,
Yeah, this is
3-methyl
the
coenzyme A reductase inhibitor.
3-hydroxy 3-methyl coenzyme A reductase inhibitor.
HMG-CoA reductase inhibitor.
And in the original recall, they asked the beneficial effect of statin on the cardiovascular patient, and they give the options like the inhibition of HMG-CoA reductase, upregulation of the hepatic LDL receptor, and increasing of the HDL receptor. And all the three are true for atorvastatin, so it was very confusing, but the most appropriate one would be the inhibition of HMG-CoA reductase. Which one is adenosine monophosphate activated protein kinase activator, AMPK?
Metformin.
This is the
Metformin.
metformin. An inhibitor of NPC1L1 inhibitor. Which one is NPC1L1?
Ezetimibe.
Yes,
Ezetimibe.
Ezetimibe, NPC1L1. So ezetimibe is the NPC1L1. Evolocumab or inclisiran, they are the PCSK9 inhibitors. Statin is the HMG-CoA reductase inhibitor. Efanicumab is a NGPTL3 inhibitor. So these are very difficult to remember, but you must memorize all the four. So statin is usually easy to remember, but these three are very difficult to remember. And fibrate is predominantly the PPAR alpha agonist. In some cases it may be PPAR delta agonist, but remember as an alpha agonist. And PPAR gamma agonist, G for gamma, G for the glutathione, actually dinadians. And sometimes they will ask you regarding the full form, so you also need to read at least once or twice regarding the elaboration. So this is our HMG-CoA reductase. Statin function as inhibitors of 3-hydroxy 3-methyl coenzyme A reductase. This blocks the rate limiting step in cholesterol biosynthesis, reduces plasma cholesterol concentration. They can be combined with other agents including fibrate, bempedoic acid, ezetimibe, PCSK9 inhibitor. Many are metabolized by the cytochrome P450 3A4. So care should be exercised when co-prescribing them with the potent P450 inhibitors. And metformin is the AMPK, and ezetimibe NPC1L1. Fibrate is the PPAR alpha receptor agonist.
So what is the most likely cause of the patient's symptoms? chlamydial pneumonia, herpes zoster pneumonia, Klebsiella pneumonia, pneumococcal pneumonia, and staphylococcal pneumonia. A 20-year-old rough sleeper is admitted to the emergency department with a fever, cough, and confusion over the past 36 hours. He has been seen 3 times over the past 12 months with the alcohol intoxication. His temperature is 38.6 degrees Celsius and blood pressure is 95 over 60 millimeter mercury. His heart rate is
الشعبي على كده مش ما شدش كويس
105 beats per minute and regular. There are coarse crackles in the right bases on auscultation of the chest. The hemoglobin is low, WBC is high, platelet is low, CRP is very high, sodium is low, potassium normal, creatinine normal, and chest X-ray there is a right lower lobe consolidation with the cavity formation. So what is the most likely cause of the patient's symptoms? So Klebsiella pneumonia.
Pneumonia plus cavitation. We have the two differential diagnoses. One is the Staph aureus, another one is the Klebsiella. So how to differentiate?
Okay, so Klebsiella, there will be the history of alcoholism.
Yes, there will be history of alcoholism in a patient with
And
Klebsiella pneumonia.
and in case of Staph aureus, there will be history of the flu influenza.
So both of them will come up with the cavitating lung lesion with the features of pneumonia or pneumonic consolidation. A for aureus, A for abscess. But spatially they comes up following the flu-like illnesses, post-influenza. And Klebsiella, this is related to cohort alcoholism, and there may be empyema formation. Patient will also have the neutrophilia. And the commonest community acquired pneumonia is the Streptococcus pneumonia. They usually comes up with the classic presentation, 3 cardinal features: rapid onset, high fever, pleuritic chest pain. And one of the most important clue is the reactivation of the herpes simplex virus presenting with the cold sore. Whenever patient comes up following cold sore or with the cold sore with pneumonia, this is the Streptococcus pneumonia. Patient will have the normal CD4 count, and there will be neutrophilia. So neutrophilia would be found in Streptococcus pneumonia as well as in case of Klebsiella. And pneumocystitis cerevisiae, they will have the low CD4 count. And whenever the CD4 count is less than 200, you need to go for prophylaxis with which drug?
Oral cotrimoxazole.
Yes, oral cotrimoxazole. And Mycoplasma pneumonia, they will come up with the dermatological target lesion related to erythema multiforme. Chlamydia psittaceae, they are related to the pigeon keepers. They will come up with the flu-like symptoms, pleuritic chest pain. And this Legionella, this is very important for the exam. So this is related to the air conditioning system. So there will be history of staying in a foreign hotel, presenting with the features of diarrhea or confusion. And the cardinal feature is the features of hyponatremia. There will be low sodium. So the patient is also having the hyponatremia, but based on the cavity formation and alcoholism, we are going for the Klebsiella, and also the Legionella isn't given in the option. A patient with a history of alcoholism and malnutrition are at much higher risk of Klebsiella respiratory tract infection. This leads to consolidation with areas of cavitation and lung abscess formation as seen here. Klebsiella is sensitive to treatment with cephalosporin, quinolones, and carbapenem, which can be used in monotherapy. And chlamydia pneumonia, this is related to the bird keepers. Herpes zoster pneumonia, they will come up with the focal calcification, usually following the chickenpox infection. And staphylococcus, this is related to the post-influenza.
So what is the most important next investigation? Arterial blood gases, blood cultures, chest X-ray, throat swab for respiratory virus PCR, and troponin I. A 77-year-old woman who has chronic obstructive pulmonary disease and left ventricular failure present to the emergency department with the coryzal symptoms, dry cough, fever, and muscle ache. Her temperature is 39 degrees Celsius. Blood pressure is 105 over 82 millimeter mercury, and the heart rate is 105 beats per minute and regular. There are coarse crackles at the left base on auscultation. The saturation is 91% on ear. So what is the most important next investigation?
So this is the patient with COPD with the left ventricular failure, currently presenting with the coryzal symptoms, tricop, fever, and the muscle ache. There's also features of pyrexia, tachycardia, and coarse crackle, and with the features of low saturation. So there may be associated COVID-19. So considering COVID-19, which investigation would be most appropriate?
Short swab for respiratory
Yes,
virus
we'll be
PCR.
going for the short swab for the respiratory virus PCR. It would be the most appropriate next investigation. Given the coryzal symptoms and muscle ache, a throat swab PCR for respiratory virus informs where and how this patient should be treated and any additional therapies that could be introduced apart from antibiotics, such as antiviral therapy for the coronavirus disease 19 infection. As such, it is important to process the sample with the point of care testing as early as possible. So although the scenario here is the COVID-19, but in the original recall, it was actually a scenario of a patient having the influenza, and they asked what should be the fastest way to diagnose the influenza. So will it be antigen testing or will it be throat swab for PCR? Which one is the fastest way? Considering
PCR.
influenza, we are considering influenza, not COVID-19. You'll be going for antigen testing or PCR. Which one is fastest?
PCR.
No, the antigen testing, the RIDT, the rapid influenza diagnostic testing. This is the fastest. You can get the result within 10 to 15 minutes. So the quickest method or the fastest method for the diagnosis of influenza, this is the antigen testing. And PCR is the most accurate and most sensitive, especially for a confirmation of the diagnosis in the high risk patient, or in case of low prevalence period, or if the antigen testing become negative. So antigen testing, this is the fastest, this is the quickest, but PCR is the most accurate, PCR is the most sensitive. So depending on the lead question, you will choose either antigen testing or you will choose PCR in case of influenza. Which drugs are used in the treatment of influenza?
Oseltamivir, zanamivir.
Yes, oseltamivir and zanamivir. Mode of action of oseltamivir and zanamivir.
Neuraminidase inhibitor.
Neuraminidase inhibitor.
Yeah, yes, these are the neuraminidase inhibitors.
What is the chance of their son being affected by the
Sorry to
condition?
interrupt. Just a quick question. Why we are not doing cultures at the first instant?
So culture will usually take a longer time, and culture is never the initial or the next investigation. Culture, yeah, it will at least take 3 to 7 days. So
Yeah,
following the
but
initial
PCR also
screening
take
test,
few days to come back.
yeah, the PCR also takes. So if we go for the blood culture, in order to, are you asking regarding the blood culture?
Yeah, I'm just asking why we are not doing blood culture and the piece.
So in case of COVID-19, the COVID-19 bacteria, they are scattered within the respiratory tract. They won't enter into the bloodstream. You need to have the systemic infection in order to enter into the bloodstream. That's why if you go for the blood culture, most likely it will come negative, because
But ideally, I think
because the
ABG is more because not all patient threshold is not 91.
sorry, repeat again, please. Not all patient.
I'm saying like ABG isn't that most important thing because not all COPD patients have target of 88 to 92. But if we are ignoring the ABG, even then, blood cultures are more important as compared to PCR.
So
Like this is what my understanding is.
Okay. So at first we need to confirm the diagnosis. See, we can also go for the arterial blood gas for the treatment purpose, for the overall treatment purpose of the patient. But at first we need to confirm the diagnosis. That's why we are going for the PCR. And since most of the specimen, most of the COVID specimen, they are found in the respiratory tract, so we will go for the throat swab. And also the blood culture, this is more suitable for the bacterial infection. Especially we need to see the resistant cases, which antibiotic is sensitive, which antibiotic is resistant. This is less suitable in case of viral infection. Okay.
Okay. So what is the chance of their son being affected by the condition? A 22-year-old man visits to the genetic clinic with his partner. He has been diagnosed with a Fabry's disease, but his partner is unaffected. They want to start a family. So what is the chance of their son being affected by the condition?
So this is the Fabry's disease. So mode of inheritance.
Recessive.
So this is X-linked recessive. So that means the defective gene is located on the X chromosome. So if we consider the son inheritance from his father, so the male will have the XY. So they will inherit the X chromosome from their mother and Y chromosome from their father. So in this case, the father has the Fabry's disease, meaning he carries the defective gene on the X chromosome. So the son will inherit the Y chromosome from his father and the X chromosome from his mother. So since the mother is unaffected, so she does not carry the defective X-linked gene. So ultimately, none of the son would be affected. So if the father is affected, if the mother is normal, so the chance of the son being affected, this is almost close to 0% or less than 5%. And in case of daughters, they have usually the 50% chance of inheriting the defective X chromosome from their father, becoming the carrier. Fabry's disease is an X-linked condition, meaning the affected men carry one affected X chromosome, one Y chromosome. For this reason, all of their sons will be unaffected by the disorder, and all of their daughters will have Fabry's disease. This is actually the carrier state. Penetration of Fabry's disease women is 70% or more, with the symptoms generally milder than men. So in the original scenario regarding the Fabry's disease, in the original recall, they directly asked what should be the mode of inheritance in Fabry's disease instead of this calculation. So the mode of inheritance is the XLR, X-linked recessive.
So what is the most likely cause of the patient's symptoms? Bipolar disorder, drug-induced psychosis, histrionic personality disorder, schizoaffective disorder, and schizophrenia. A 24-year-old man is brought to the emergency department by the police. He told them that he has a son of God. He's the son of God, and had been trying to break the window of the local store because of the devil is broadcasting through the television. He has also tried to slit his wrist because voices are telling him to kill himself. He has covered his room in tinfoil because he is concerned that the devil is transmitting the message to his brain. So what is the likely cause of the patient's schizophrenia?
Also, son of God, this points towards the delusion of grandeur. Patient is also having the features of thought broadcasting, thought transmission. So the most likely diagnosis is the acute schizophrenia. So how will you what should be the treatment?
Risperidone.
The
Yes, we'll be
atypical
going for the
antipsychotic, yeah,
atypical
respiratory.
antipsychotic, especially risperidone. Alternative to risperidone, what other drugs can be used that
Does it
leads
link?
to the weight gain?
Olanzapine.
Yes,
Olanzapine.
we can go for
Yeah,
the
olanzapine.
olanzapine. And for the chronic treatment of olanzapine, patient may also comes up with the features of diabetes, but commonest adverse effect is the weight gain. This patient has a significant delusion, believing he is the son of God, and the devil is transmitting message into his brain via the television. He appears to have no insight into his illness, consistent with an underlying diagnosis of schizophrenia, and atypical antipsychotic agents such as risperidone is the initial interventions of choice. And bipolar disorder, they have combination of mania and hypomania, but there will be no thought disorder. In case of bipolar disorder, drug induced psychosis will have the features, will have the history of the drug intoxication. And histrionic personality disorder, they usually have the pattern of attention seeking behavior. And it's schizoaffective disorder, along with the mild features of schizophrenia, they will have the features of delusion and hallucination, or there will be low mood or disordered mood.
What is the most appropriate way to treat the patient's hyponatremia? 1.8% sodium chloride, demeclocycline, fluid restriction, hydrocortisone, tolvaptan. A 74-year-old man smokes 10 cigarettes per day, is admitted to the emergency department with the cough and chronic confusion. According to his son, he has become increasingly tired and confused over the past 3 weeks. His blood pressure is 123 over 60 millimeter mercury, and the heart rate is 75 beats per minute and regular. On auscultation of the chest, he has a wheeze consisting of COPD. Hemoglobin is low, 110 gram per liter. WBC normal, platelets normal. Sodium is low, 118 millimole per liter. Potassium normal, creatinine normal, and in chest X-ray, there is a left hilar mass. So what is the most appropriate way to treat the patient's hyponatremia?
So most likely diagnosis in this patient.
Siad,
Small cell carcinoma.
So this is the paraneoplastic lung cancer presenting with hyponatremia. So it can be explained by SIADs, which usually occurs in a patient with small cell lung cancer. And in case of squamous cell, what should be the association?
hypercalcemia.
Yes, there would be hypercalcemia due to increased release of the
Parathyroid
parathyroid
hormone.
hormone related
Hormone.
peptide. So in case of adenocarcinoma, this usually A for adenocarcinoma, A for abstinent smoking, A for asbestos exposure. Squamous cell carcinoma with hypercalcemia. Small cell lung cancer, they are usually associated with the endocrine disorder like SIADs, Cushing syndrome, Lambert-Eaton myasthenic syndrome. All the three are important in favor of small cell lung cancer. Also, in case of paraneoplastic cerebellar degeneration, there may be underlying small cell lung cancer. And bronchial carcinoid, this usually occurs in a young patient. Patient usually comes with recurrent hemoptysis. There will be features of bronchial obstruction, and if you go for bronchoscopy, there would be cherry red type of lesion. So in this scenario, this is the SIADs as a result of underlying paraneoplastic small cell lung cancer. And the patient is having the normotension, meaning there is no hypotension. So what should be the first step for the management of hyponatremia in SIADs?
Fluid restriction.
Fluid
Yes,
If there is
we'll
restriction.
be going
normotension.
for
Fluid
the
restriction.
fluid restriction. And second step,
Democycline.
yes, we'll be
Yeah.
going for the
Demeclocycline.
demeclocycline. And in the third step, we can go for the
Tolvaptan.
tolvaptan. What is the mode of action of tolvaptan?
Vasopressin receptor antagonist.
Yes,
Yes.
it's the vasopressin receptor antagonist. So other than SIDs, this is commonly used in which condition? PKD, autosomal dominant polycystic kidney disease. And 1.8% sodium chloride, this is indicated in case of severe hyponatremia present with the life-threatening neurological symptom like features of coma on the seizure. Previously, few days ago, some of the doctors are discussing this question, and they were diagnosing it as an typical case of hyponatremia, but actually this is a case of paraneoplastic small cell lung cancer leading to hyponatremia as a result of the SIAD. So that's why the most appropriate or the first line choice of treatment should be the fluid restriction. So what are the precondition, or what are the essential criteria for diagnosing SIADH? What are the essential criteria? Anyone?
Serum sodium is less than 130. Urinary sodium is more than 30.
20 plasma osmolality is less than 50
No, no, I'm asking essential criteria. I'm not asking regarding the parameters or regarding the I'm asking about the essential criteria. What are the criteria that should be fulfilled? They are you need to exclude some other condition like the patient. Sorry, this not.
Adrenal gland, thyroid gland dysfunction.
C.
Yes, go on.
Renal failure, adrenal insufficiency, dehydration, and হচ্ছে heart failure বা fluid overload.
So there will be some of the essential criteria. Patient will have normal renal, normal adrenal, normal thyroid function. So you need to assess this. If the patient is having abnormal renal function, abnormal adrenal function, abnormal thyroid function, this is not SIADs. There will be no recent use of diuretics. Patient will be in a clinical euvolemic condition. There will be decreased serum osmolarity. There will be increased urine osmolarity. And the urine sodium, this is typically greater than 20. Greater than 20, this is the precondition. But in most of the cases, this is greater than 40. And in case of ATN, acute tubular necrosis, the precondition for urinary sodium is greater than 40, but in most of the cases, this is greater than 60. So fluid restriction is the first line. Second line is the demeclocycline. Demeclocycline blocks the action of antidiuretic hormone at the distal renal tubules, increases free water clearance, thereby increasing the serum sodium concentration. And always remember, intranasal desmopressin or desmopressin, this is contraindicated in a patient with SIADs. This patient has a hilar mass which may be due to an underlying small cell lung cancer. Against a background of smoking, small cell lung cancer are recognized to produce ADs, which likely account for confusion and hyponatremia. Seen here in the first instant, fluid restriction is appropriate. Although additional demeclocycline may be added to induce renal diabetes insipidus, treatment of the underlying cancer can reduce ADS production and improve symptoms. Volume of 1.2 liter per 24 hours is a usual starting point for targeted restriction of the fluid. And whenever, in case of true hyponatremia, patient comes up with the life-threatening neurological symptoms, you can go for the 1.8% sodium chloride.
Sir, can you please repeat SIADH diagnostic criteria?
There will be normal renal adrenal thyroid function, no recent use of diuretics, clinical euvolemic condition, decreased serum osmolarity, increased urine osmolarity. So this is known by everyone. Clinical euvolemia, this is also common. So you need to remember normal renal adrenal thyroid function. There should be no recent use of diuretics.
Thank you.
What's the most appropriate next step? The blood patch, pleurodesis, clamping of the drain, high flow suction, talc pleurodesis, video assisted thoracoscopic pleurodesis. A 64-year-old man is reviewed to the respiratory ward 5 days after the insertion of the chest drain for a large spontaneous pneumothorax. He has COPD, treated with the dual inhaled therapy. The chest drain is continuing to bubble. So what is the most appropriate next step?
So this is our secondary spontaneous pneumothorax treated with the chest drain. There is presence of bubbling after 5 days. So what should be the next step?
Video assisted thoracoscopic pleurodesis.
Yes, we'll be going for the fats pleurodesis. So here is our criteria and pneumothorax. When training a pneumothorax, after 3 to 5 days, if there is a persistent air leak, meaning coming up with the bubbling of the chest drain, as in this scenario, or if there is failure of the lung to re-expand, then we need to go for the thoracic surgical opinion, meaning we'll be either going for the VATS pleurodesis or we can go for the surgical resection. Usually initial one is the VATS pleurodesis. So what are the indication of video assisted thoracoscopy in a patient with pneumothorax? Indication of VATS. So these are the indication of VATS. So this is usually more important for the part 2. So you can just remember regarding this one. There would be if there is persistent air leakage. So based on the past medicine, this is written as 3 to 5 days, and based on the BMC, they have given us 5 to 7 days following the chest drain. So if there is persistent air leakage, meaning persistent bubbling, or if there is failure of the lung expansion following chest drain after 3 to 5 days or after 5 to 7 days, you'll be going for the video assisted thoracoscopic surgery or pleurodesis. Usually pleurodesis is the initial step. No response, in that case we can go for the surgery. The video assisted thoracoscopic repair of this persistent air leak is the intervention of choice given this patient history of COPD and the high risk of a medical procedure such as blood patching and failure to seal the hole. Other procedures such as talc pleurodesis are usually reserved for malignant effusion. Blood patching is an option if the patient refuses or is unable to undergo surgery. Blood patch pleurodesis is usually considered for patients with persistent air leak related to pneumothorax, which are unable or unwilling to undergo surgery. This patient COPD puts them at a high risk recurrence, meaning the video assisted thoracoscopic repair is the definitive procedure. This as the definitive procedure is preferred.
So what is the most likely cause of the patient's bleeding symptoms? Factor 7 deficiency, factor 8 deficiency, factor 9 deficiency, factor 11 deficiency, and the von Willebrand disease. A 23-year-old woman is referred to the hematology clinic after an episode of prolonged bleeding following the extraction of the 2 wisdom teeth. She also reports that her periods have always been heavy. Hemoglobin is low, platelet normal, WBC normal, PT normal, and APTT is prolonged. So causes the von Willebrand disease.
So young female patient presenting with either menorrhagia or prolonged bleeding following the dental extraction or minor surgical procedure with normal APTT or with prolonged APTT, the most likely diagnosis is the von Willebrand disease. So in 50% cases, the APTT would be prolonged. In another 50% cases, APTT would be normal, and the proton beam time will always be normal in a patient with von Willebrand disease. So mode of inheritance.
Autosomal dominant.
Yes, this is the autosomal dominant. How to differentiate between von Willebrand disease and hemophilia?
Factor
Differentiating.
8 hemophilia will more commonly in
So in
male
case of
child.
hemophilia, the APTT will always be prolonged, and the bleeding time would be normal. But in case of von Willebrand disease, the PT would be normal, bleeding time would be prolonged, APTT may be prolonged, may be normal. So differentiating point is with the PT and with the bleeding time. And also since the von Willebrand disease, this is an autosomal dominant, so it will equally affect both male and female. And hemophilia usually affects the male patient. And if you go for the restorating platelet aggregation test, in case of von Willebrand disease, there will be impaired aggregation, and in case of hemophilia, there will be normal platelet aggregation following the restorating. So factor 8 deficiency, it will carries the autosomal recessive pattern of inheritance, and in this case the prothrombin time would be prolonged, and the APTT will be within the normal range. And the factor 8 and factor 9, both of them will carry the X-linked pattern of inheritance, meaning the women, they don't usually have the clinically significant disease, and they usually don't suffer from the bleeding events. And factor 11 deficiency, it also carries the autosomal recessive pattern of inheritance. So whenever you find young female patient presenting with menorrhagia or prolonged bleeding following dental extraction or minor surgical procedure, most likely diagnosis is the von Willebrand disease. Von Willebrand disease is subject to autosomal dominant. So in rare cases, there may be autosomal recessive, but you should remember it as an autosomal dominant. Leads to an increased risk of bleeding. Up to 50% of patients with VWD have prolonged APTT, although some women who carry the hemophilia gene may also have slightly prolonged APTT, and this does not usually lead to clinically significant disease. The prolonged APTT seen in von Willebrand disease, this is due to low levels of factor 8, because von Willebrand factor protects factor 8 from degradation. And the treatment of choice for patient with type 1 von Willebrand disease, because it causes a rise in both von Willebrand factor and factor 8 concentration within 30 to 60 minutes.
What is the most likely cause of the patient's symptoms? Neurofibromatosis type 1, neurofibromatosis type 2, Charles-Weber syndrome, tuberous sclerosis, von Hippel-Lindau syndrome. A 18-year-old man who lives in the assisted living accommodation is admitted to the emergency department with the status epilepticus. His seizure activity appears predominantly left-sided, and he has port wine stain affecting the right side of the forehead and the upper eyelid. What is likely cause? Charles Weber.
So port 1 stain with the history of seizure, most likely diagnosis is the Sturge-Weber syndrome. So this port 1 stain, this is the pathognomonic features. These are the deep purple colored lesions, especially around the eyes. And neurofibromatosis type 1, so this is the peripheral neurofibromatosis. So they usually comes with the features of axillary freckling or with the cafe or lay spot. Neurofibromatosis type 2, this is the central neurofibromatosis. Most common association is the vestibular schwannoma. So what are the three cardinal features of vestibular schwannoma? Tinnitus,
Absent corneal
vertigo.
reflex.
There will be hearing loss, tinnitus, and the vertigo. These three are the cardinal features of vestibular schwannoma, which is most commonly seen in case of neurofibromatosis type 2. Tuberous sclerosis, they also comes up with the features of seizure, but what should be the presentation or features of tuberous sclerosis? Ash-lip macule. Then what are the other features?
Anguino.
Chagrin patches.
Yes, there will be chagrin patches. Ashley
Patches.
macule,
Ungual fibroma. Yeah.
adenoma sebaceum, ungual fibroma, retinal hamartoma. So Ashley macule means there will be depigmented skin patch. Adenoma sebaceum means there will be red spot or papule affecting the nose, nasolabial fold, cheek or chin. Ungual fibroma, smooth fleshy growth adjacent to the fingernail. Retinal hematoma, there should be translucent curvilinear band-like lesion emitting from the retinal periphery, and investigation of choice would be the MRI of the brain. The VHL, what is the mode of inheritance of VHL?
Autosomal dominant.
Yes, autosomal dominant. So usually all the hepatic disease, they follows the autosomal recessive pattern of inheritance. Only exception is the VHL, and patient with VHL, they'll come up with the features of retinal and cerebellar hemangioblastoma. So cerebellar hemangioblastoma, retinal hemangioblastoma, they are usually more common, and patient may also come up with the features of subarachnoid hemorrhage. So there would be features of vitreous hemorrhage or retinal hemorrhage due to retinal hemangioblastoma. Patient will come up with the features of ataxia or cerebellar hemorrhage as a result of cerebellar hemangioblastoma. This is also associated with the pheochromocytoma. So VHL is related to pheochromocytoma, and patient may also have the renal cyst. Sturge-Weber syndrome is associated with the Port-von stain, which is unilateral and affects the upper face, and epilepsy when the seizures activity is seen in the opposite side. Seizures occur due to development of the leptomeningeal angiomas, which affect the surface of the brain, become calcified over time. Progressive cognitive impairment is seen. So this is peripheral. This is central with the vestibular schwannoma. Tuberous sclerosis will come with the features of AAUR with history of seizure, and VHL will have the hemangioblastoma.
It is the most useful investigation to confirm the diagnosis. Autoantibody screen, electromyography, lumbar puncture, MRI of the cervical spine, and the muscle biopsy. A 54-year-old man is referred to the neurology clinic. He is having difficulty with swallowing and walking and has problem with the fine movement of his hands, which are interfering with his job as an electrician. There are mixed upper and the lower motor neuron signs with the increased tone and weakness of the arm extensors and decreased tone with the bilateral foot drop on examination of the legs. No sensory loss is present. What is the most useful investigation to confirm the diagnosis?
So mixed upper and lower motor neuron lesion with no sensory loss with the features of bulbar involvement. So most likely diagnosis.
Motor neuron
Yes, this
disease.
is the MND, motor neuron disease. So considering MND, what should be the most useful investigation?
EMG.
Yes, we will be going for the electromyography. And treatment options for MND.
Non-invasive ventilation.
One is the non-invasive ventilation. Another one is the Riluzole. Which one is
Riluzole.
better?
NIV.
Non-invasive ventilation.
Yes, non-invasive ventilation is a better choice. But in case of amyotrophic lateral sclerosis, the most common variant, usually we go with the Riluzole. This patient has mixed upper and lower motor neuron dysfunction with intact sensation. Given the absence of other features, this marks out MND as the most likely cause of his symptoms, for which electromyography is the most useful investigation. Electromyography reveals polyphasic motor units with the presence of fibrillation and fasciculation. The greatest innovation with respect to treatment in recent years has been the recognition of the value of NIV in managing the fatigue. And autoantibody profile, this is for ruling out the inflammatory myositis like the polymyositis, and especially the muscle biopsy is the definitive investigation of choice in case of polymyositis.
What is the most likely cause of the patient's symptoms? G2 dopamine receptor antagonism, impaired serotonin up into the presynaptic neuron, increased serotonin release, reduced hepatic clearance of codeine, reduced renal clearance of lithium. A 36-year-old woman present to the emergency department with fever, muscle rigidity, drowsiness, and confusion. She is treated with a long-term lithium for bipolar disorder and has recently been prescribed tramadol for a back injury. Her temperature is 39 degrees Celsius, blood pressure is 155 over 90 millimeter mercury, and the pupils are dilated. Muscle tone is increased, and there is a hyperreflexia with the spontaneous clonus. So, what is the most likely cause of the patient's symptoms?
So most likely diagnosis.
Serotonin syndrome.
Yes, most likely this is the serotonin syndrome. So most likely cause of this patient's symptoms, I mean pathophysiology of serotonin syndrome.
Impaired serotonin reuptake.
Yes, this is the impaired serotonin reuptake in the presynaptic neurons. Serotonin syndrome. So this is more commonly seen when the serotonergic drugs are used, like the SSRI, citalopram with tramadol or lithium. Patient will comes with the features of hyperpyrexia, hyperreflexia, clonus, increased muscle tone. And the underlying pathophysiology is the impaired serotonin reuptake into the presynaptic neurons. And for the management, we can go for the benzodiazepine as well as the cyproheptadine. So how to differentiate serotonin syndrome from NMS, neuroleptic malignant syndrome?
In case of serotonin syndrome, there will be hyperreflexia, and NMS is a hyperreflexia.
So in case of neuroleptic malignant syndrome, there should be history of taking the antipsychotics, or there should be history of abrupt cessation of antipsychotic medication. In case of serotonin syndrome, there should be history of taking the antidepressant, either SSRI or tricyclic antidepressant. In NMS, patient will have hyperreflexia, led by rigidity, normal pupil. In case of serotonin syndrome, hyperreflexia, clonus, dilated pupil. So look at the history of the drug. It will help you to differentiate antipsychotics related to NMS, antidepressant related to serotonin syndrome. So D2 dopamine receptor antagonism, this is related to the NMS, neuroleptic malignant syndrome. When tramadol and lithium are used together, this drives a reduction in the reuptake of serotonin from the synaptic cleft into the presynaptic neuron. This leads to symptoms of serotonin syndrome. The diagnosis here with pyrexia, hypertension, dilated pupil, increased muscle activity. Tramadol should be withdrawn immediately. Benzodiazepine and cyproheptadine, a mixed histamine receptor antagonist, are the potential interventions.
What is the most likely diagnosis? Bacterial folliculitis, human herpes virus infection, human papilloma virus, lichen planus, molluscum contagiosum. A 20-year-old woman is referred to the dermatology clinic for umbilicated lesions that have appeared over the past few months. They affect the line of her wristband and her buttocks in particular. She says that when she scratches the lesion, they occasionally leave a scar. And he has no underlying medical illness and play hockey in a local team. What is the most likely diagnosis?
So most likely diagnosis.
Molluscum contagiosum.
Yes, this is the molluscum contagiosum. They usually comes up with the recurrent umbilicated lesions, especially the vesicular or papular pattern. And this is more commonly seen in the in a very young age, like around 6 years or within 10 years, but it can also affect the young adult. So how to treat molluscum contagiosum?
the
Yeah.
problem.
Self-resolving.
Yes, this is the self-resolving condition, so just go for the reassurance. And human herpes virus 6 infection, this is related to which condition?
Uh,
Most sorry, the Kaposis sarcoma. Kaposis is related to most probably 8.
yeah,
Eight.
capacity is
Yeah,
8.
Kaposi
Virus
is
8.
8. Kaposi is 8. And
And
human
7
papilloma.
is
Human papilloma has the most probably the strain 1831
Sir,
33 this time.
yeah, yeah.
They are
8.
related to the
Second, third,
anogenital cancer.
cancer.
And the
And
and
herpes,
esophageal cancer.
lichen planus will comes with the features of 5P, planar, purple, papular, polygonal, this type of presentation, and there should be the cardinal Wickham stria, white lace pattern on the buccal mucosa. How to treat a case of lichen planus?
Topical.
topical,
Steroid. Topical
Steroids.
steroid.
potent
Topical
topical corticosteroid.
potent steroid. Topical potent steroid. Molluscum contagiosum leads to crops of umbilicated lesion, often found around the inner thigh or genital region. This is caused by pox virus, which may be spread by fomites such as towels or shared sports gear. Most cases clear without intervention around 18 months, although auto inoculation can lead to the appearance of more lesions. Patients should be encouraged to avoid scratching because of scarring and the risk of infection. And bacterial folliculitis, this is inflammation of the hair follicles. So this 6, this causes the roseola infantum. And HPV 16, 18, 31, 33. And lichen planus, they will come with the features of P with the Wickham stria. And LP will predominantly have the flexural involvement. Next.
Which feature is the most important contraindication against pneumonectomy? Age 65, FEV1 1.7 liters, hypercalcemia, right upper lobe cancer, vocal cord palsy. A 65-year-old man is assessed in an oncology clinic following a diagnosis of squamous cell carcinoma of the bronchus. He has a worse voice and a paralyzed right vocal cord is noted. Hemoglobin is low, WBC is high, iron normal, platelet normal, sodium low, potassium normal, calcium is high, chest fracture, right upper lobe cancer, and the FEV1 is 1.7 liters. So most important contraindication
So
against
important
pneumonectomy.
contraindication against pneumonectomy in patient with lung malignancy. So which one is most important contraindication for pneumonectomy?
FEV1 1.7 liter.
So FEV1 less than 2 liter in case of pneumonectomy, and FEV1 less than 1.5 liter in case of lobectomy. This is the relative contraindication. This relative
The vocal cord
contraindication
palsy.
and the absolute contraindication, this has been discussed or provided in details in the PMC respiratory, but you can simply remember these two parameter 1.5 and the 2 liters regarding the this is related to the relative contraindication. So for pneumonectomy, FEV1 less than 2 liter, and for lobectomy, FEV1 less than 1.5 liter. This is the relative contraindication. And absolute contraindication is the vocal cord palsy. Vocal cord palsy, this indicates the metastatic infiltration. So this is the absolute contraindication for the pneumonectomy. Focal cord palsy is the most important contraindication against pneumonectomy. This is because it implies local invasion, meaning the pneumonectomy would not convey a survival advantage, and this is likely to be assisted with a significant operative morbidity. In place of surgery, this patient should be offered access to chemotherapy and the radiotherapy. So this is the relative contraindication. So in the last portion of the FEV1. So this is our page 152. So for from page 152 up to last, this all the points have been discussed regarding the absolute contraindication and the relative contraindication, but simply you can remember regarding the 1.5 liter and 2 liter, they are relative contraindication. Focal cord burst is the absolute contraindication.
Yeah. What is the best way to manage the patient's lupus? Add belimumab, add prednisolone, continue hydroxychloroquine only, switch hydroxychloroquine to infliximab, switch hydroxychloroquine to mycophenolate mofetil. A 43-year-old woman who has SLE present to the rheumatology clinic for review. She says that although her joints are controlled on hydroxychloroquine, she is feeling increasingly tired over the past few months. Her blood pressure is 149 over 89 millimeter mercury, and the heart rate is 83 beats per minute and regular. Her BMI is 22 kg per meter square. Hemoglobin is low, WBC normal, platelets normal, sodium potassium normal, creatinine is high, and there is blood 1 plus and protein 2 plus in the urine.
So this is our lupus nephritis. So how to treat lupus nephritis? We should go
Switch
for the mycophenolate mofetil.
mofetil.
Hydroxychloroquine is the intervention of choice for joint disease associated with the lupus. However, for patient with active renal disease, as is likely here, mycophenolate mofetil is preferred. The usual starting dose of mycophenolate mofetil is 500 microgram twice daily for the first week. It's increased to 1 gram twice daily from week 2 for patient with highly active lupus. Prednisolone may be used in combination. And belimumab, this is for isolated SLE not responding to conventional hydroxychloroquine or MTX.
What is the most appropriate next investigation? Abdominal ultrasonogram, colonoscopy, dental examination, endoscopic retrograde cholangiopancreatography, magnetic retrograde cholangiopancreatography. So a 57-year-old man is admitted to the cardiology ward with a new onset murmur and fever. Blood culture results are positive for Streptococcus bovis, and echo confirmed the diagnosis. So colonoscopy.
In case of infective endocarditis etiology, if the Streptococcus bovis or Streptococcus subtype Streptococcus galolyticus is suspected, this is most commonly associated with the colorectal cancer. In some cases, this may also be related to the hepatobiliary pathology. So whenever bovis is suspected or galolyticus is suspected, the immediate investigation or next investigation of choice would be the colonoscopy. If the colonoscopy is contraindicated, in that case, alternative investigation would be the CT abdomen. If colonoscopy or CT abdomen excludes the colorectal cancer, then the next step would be to go for MRCP to look for the hepatobiliary pathology. So the first line investigation would be colonoscopy. Colonoscopy contraindicated, go for CT abdomen. Colonoscopy or CT abdomen excluding colorectal cancer, go for MRCP to look for the hepatobiliary pathology. And in which condition we'll be going for the dental examination, dental OPG.
Streptococcus and sanguinis.
Yeah. Streptococcitis or sanguinis or oralis.
Mitis or sanguinis, they falls under the Streptococcus viridans pattern. So the viridans would be suspected if the patient has the poor oral hygiene or if there is history of the dental extraction. Streptococcus bovis endocarditis is the most likely diagnosis. The most likely diagnosis here is most strongly associated with the colon cancer. Case studies says between 25% to 80% of cases are associated with an underlying colorectal tumor. This makes colonoscopy the most useful investigation in patient where investigation of the colon is unremarkable. The biliary tree should be investigated next, as Streptococcus bovis may also be associated with the biliary tract infection and the cirrhotic bacteremia.
What is the most likely cause of the patient's symptoms? Angle closure glaucoma, central retinal artery occlusion, keratitis, optic neuritis, and scleritis. A 62-year-old man present to the emergency department with a sudden onset left eye pain and severe left-sided headache. He says that symptoms began with the blurred vision a few hours earlier, and his acuity is reduced on a counting fingers only. The toe feels hard to touch, and there is a ciliary flush. So, what is the most likely cause of the patient's symptoms?
Angle closure glaucoma.
So this is the angle closure glaucoma. So how to differentiate the acute angle closure glaucoma and acute anterior uveitis? Differentiating point.
In case of angle closure glaucoma, the pupil will be semi-dilated,
Yes,
and
pupil
in
would
case
be
of
semi-dilated. It will felt as an hard globe, and in case of uveitis, there should be constricted pupil.
myosis, yeah.
So how to treat acute angle closure glaucoma?
Topical pilocarpine with IV acetazolamide.
Yes, very good.
Yeah.
Topical pilocarpine and IV acetazolamide. Mode of action of pilocarpine.
Pilocarpine is muscarinic agonist and acetazolamide is carbonic anhydrase inhibitor.
Yes, and atropine.
Atropine is muscarinic antagonist.
Yes, very good. So the mydriatic drop, meaning the muscarinic receptor antagonist, like the atropine, they are the precipitating factor for acute angle closure glaucoma. In case of glaucoma, the pupil would be dilated. So we'll be using the drug that causes constriction of the pupil, like the pilocarpine, and pilocarpine is the agonist. And how to treat a case of acute anterior uveitis?
Topical
Steroid and antibiotic.
Is topical steroid and topical atropine. So in case of uveitis, there would be constricted pupil. So we'll be going for the mydriatic drop. And how to differentiate scleritis from episcleritis?
In episcleritis, no pain.
Full and episcleritis is not painful.
Yes, the scleritis is painful, episcleritis is painless, or there may be mild pain, and the predominant features is the foreign body sensation. And keratitis presentation, this will also comes up with the acute painful red eye. There should be sensation of foreign body. The differentiating point is that there would be blurring of the vision. In case of keratitis, there should be blurring of the vision. And in case of optic neuritis, there would be loss of color vision, or there would be reduction in the visual acuity, and there will be features of the relative afferent pupillary defect. The rapid deterioration in vision coupled with ciliary flush and a hard loop fits best with an episode of acute angle closure glaucoma. Intraocular pressure should be measured, and a pressure of above 21 mm of mercury is confirmatory. IV acetazolamide is used acutely. Topical therapies include beta blocker, corticosteroid, pilocarpine. After a single uncomplicated episode of acute angle closure glaucoma, the prognosis is usually considered excellent. So how to differentiate central retinal artery occlusion from central retinal vein occlusion?
In artery occlusion, there will be pale retina, red macula,
Red
and
background.
Yes,
And
so
which
in
is
case of
the hemorrhage will be near the vein occlusion.
blood hemorrhage with vein occlusion.
so both of the condition will comes up with the sudden painless loss of vision. And in case of central retinal vein occlusion, there would be a history of the either deep vein thrombosis or diabetes mellitus or dyslipidemia, and they will come up with the flame-shaped hemorrhage with the stormy sunset appearance. And central retinal artery occlusion, they will come up with the pale retina with the shady red spot. And CMV retinitis, this exclusively occurs in the immunosuppressed patient. So V for vein, and here is also V. So they will also have almost the similar picture, that of the retinal vein occlusion, presenting with picture retina or flame-shaped hemorrhage.
What is the most likely cause of the patient's symptoms? Acute gout, pre-patellar bursitis, pseudogout, rheumatoid flare, septic arthritis. A 54-year-old woman who has rheumatoid arthritis is admitted to the emergency department 48 hours after receiving an intra-articular corticosteroid injection into the right knee. She has a temperature of 38.6 Celsius and knee is swollen and red. The flexion is limited to 30 degrees. So what is the most likely cause of the patient's symptoms?
So most
Septic
likely
arthritis.
diagnosis, most likely this is the
Septic arthritis.
septic arthritis. In cases, this is usually followed by the intra-articular corticosteroid injection. So in case of septic arthritis, should we go for synovial fluid culture first or blood culture first? What should be the parameters to decide?
If more systemic symptoms, then blood culture, or if localized symptom, then synovial fluid culture.
So this septic arthritis, this usually develops within 3 to 4 days of the intra-articular injection, but in some cases the presentation can be delayed. Septic arthritis, this is a potential catastrophic complication of intra-articular steroid injection. So to decide whether we should immediately go for blood culture or we should go for arthrocentesis with the synovial fluid culture, we need to look at the association with the sepsis or septic shock. If the patient has features of sepsis or septic shock like hyperpyrexia, hypotension, tachycardia, we'll immediately go for the blood culture, immediately starting empirical antibiotic followed by the synovial fluid culture. If there is no features of associated sepsis or septic shock, we'll be going for the arthrocentesis plus synovial fluid culture along with the microscopy, and this microscopy, it will reveal whether this is gout or pseudo gout, and culture will reveal whether this is septic arthritis. Which empirical antibiotics is used in case of septic arthritis? IV,
Flu-
hydroxychloroquine,
flucloxacillin.
Oxacillin.
and based on the joint fluid microscopy under the polarized light, how can I differentiate whether this is gout or pseudo gout?
Negative needle shape is the gout. Positive rhomboid shape is the pseudogout.
So the P features like the positive pyrophosphate, this would be found in case of CPPD crystal in pseudo gout, and it would be negatively pyrofluorescent or monosodium in case of acute gout. Which condition comes up with the chondrocalcinosis?
Pseudogout.
Yes,
Pseudo
pseudo gout
gout.
will have the chondrocalcinosis. So what is meant by chondrocalcinosis? X-ray will show calcification
Linear
of the
calcium
Linear
calcification of the triangular fibrocartilage. So either they will directly mention chondrocalcinosis or they will give you the X-ray findings. X-ray shows calcification of the triangular fibrocartilage, and patient comes up with the monoarticular presentation. You will be going for the acute pseudo gout. And what should be the presentation in pre-patellar bursitis? This is also known as the housemaid's knee. So this is usually precipitated by the repeated nailing, especially in the carpet feeders. Septic arthritis is the most likely cause of this patient's symptoms given the very recent corticosteroid injection into the knees. Aspiration for microscopy, culture and sensitivity is the next step. Antibiotics should be started before the results are available, with flucloxacillin as the default option given the likelihood of staphylococcal infection. In the event that septic arthritis is confirmed, then washout should be considered. And this is housemaid's knee related to repeated nailing and pseudo gout and will also comes up with the single flamed joint.
Which of the following is a short-term physiological response to the levothyroxine in a hypothyroid patient? Decreased calcitonin concentration, decreased osteoblast activity, decreased hydroxylated vitamin D concentration, increased osteoclast activity, increased thyroid stimulating hormone concentration. 42-year-old woman is diagnosed with the Hashimoto's thyroiditis is commenced on levothyroxine replacement therapy. The short-term physiological response to levothyroxine in a hypothyroid patient.
Increased osteoclast activity.
So the short-term physiological response to levothyroxine in a hypothyroid patient, it would be the increased osteoclast activity. So this hypothyroidism, it usually leads to the decreased bone turnover and increased bone mineral density due to the reduced activity of both osteoblast as well as the osteoclast. So once the levothyroxine therapy is initiated, the thyroid hormone level, it will be normalized, and this normalization of the thyroid hormone, it will stimulate both osteoblast as well as the osteoclast, but the more pronounced effect would be about the osteoclastic activity. So it will lead to the increased bone resorption, and there will also be decreased bone mineral density. So this hypothyroidism, this is associated with the decreased calcitonin concentration, but this levothyroxine therapy, it will causes reversal of the condition, and there will be increased osteoblastic activity, and there will be no change on the vitamin D concentration, and this is our answer: increased osteoclast activity. And the in case of levothyroxine, following levothyroxine treatment, there would be decreased bone mineral density in patient with hypothyroidism, and the bone turnover with remodeling is reduced. Once thyroxine replacement is commenced, there is increase in both osteoblast and osteoclastic activity. So there will be increase in both activity, osteoblast as well as the osteoclast, but more pronounced occur in case of osteoclastic activity. So there would be increased osteoclast activity.
So BMD will be decreased, no?
Yes, the bone mineral density will be decreased. There'll be
Decreased.
just a slight reduction, a slight reduction in the short term.
Okay.
Okay, next.
What is the most likely cause of the patient's symptoms? Amoebic liver abscess, hepatocellular carcinoma, hydatid cyst disease, leptospirosis, schistosomiasis. A 28-year-old man present to the emergency department with a vague right upper quadrant abdominal pain and the night sweats over the past few weeks. He has recently returned from teaching in Kenya. He says he has lost 3 kg in weight. The abdominal examination reveals hepatomegaly with a tenderness in the right upper quadrant. Hemoglobin is low, 109 gram per liter. WBC is high. CRP is high. Platelet is low. Sodium normal. Potassium normal. Creatinine is normal. And in abdominal CT, 2 large simple liver cysts with a reduced attenuation and the wall thickening. Small rim of edema around the cyst. So what is the most likely cause of the patient's symptoms?
So most likely cause of the symptoms, is it hydatid disease or is it amoebic liver abscess?
Amoebic liver.
Yes, this is the amoebic liver abscess. In case of hydatid cyst, we'll get the features of daughter cyst. And usually the presentation in amoebic liver abscess usually will have the single cyst, but in some cases there will be more than one lesion, and they are usually rounded, homogeneous, and well demarcated. And they will also come up with the features of leukocytosis with the deranged liver function test. And within the region Kenya, the amoebic liver abscess, this is more common. And what should be the choice of treatment?
Ceftriaxone.
Antiprotozoal. Not ceftriaxone. Yes, we can. We need to go for a combination of two drug, most probably ceftriaxone plus metronidazole. This combination is more commonly used. This
Isn't it
patient,
plus diloxanide furet?
diloxanate furet, it can also be used, but usually the initial choice of treatment is combination of ceftriaxone plus metronidazole. This is more commonly used. This patient's symptoms: hepatic enlargement, raised CRP concentration, low platelet count, coupled with changes seen on the CT scan are consistent with the amoebiasis. This is not usual for the patient to present with the liver disease with an absent diarrhea history. Infection is likely to have occurred in Kenya. Most patient response to per oral metronidazole, although particularly larger complexes, may be suspect to percutaneous strains. Is there any incubation clue? Yeah. So there is also something like close regards to the incubation and long incubation period, usually greater than 7 days. This is related to amoebiasis and the giardiasis. And the patient with amoebiasis can also present with the amoebic liver abscess. Hydrated disease of the liver generally has a slightly different pattern of changes on the CT with a more complex appearance into the cyst, including areas of the peripheral calcification.
So what is the function of lysosome? DNA replication, DNA transcription, post-translational protein modification, protein assembly, protein degradation. You are investigating a cause of lysosomal storage disorder that leads to progressive neurological dysfunction, muscle weakness, and cardiac failure. So function of lysosome.
So function of lysosome. This is one type of either you know it or you don't know it type question. Lysosome. So lysosome causes the protein degradation, ribosome causes protein assembly, Golgi bodies causes the post-translational modification of lipid molecules, and the DNA replication occurs within the DNA polymerase, and DNA transcription occurs within the nucleus. So lysosome for the protein degradation, especially the intracellular protein. Lysosomes are responsible for degradation of macromolecules, including intracellular protein. These are particularly important for breaking down and recycling of malfunctioning organelle, and in some cases can drive apoptosis in cases where a cell is irreversibly damaged. So DNA replication is primarily driven by DNA polymerase, DNA transcription occurs in the nucleus, and DNA is transcribed by the RNA polymerase. Post-translational modification of lipid molecule takes place in the Golgi body. Ribosomes are responsible for protein assembly. So assembly for ribosome and degradation for the lysosome.
What is the most appropriate next step? Adrenaline, amiodarone, continue cardiopulmonary resuscitation, further direct current shock, lidocaine. A 54-year-old man is managed to the coronary care unit following an inferior MI. He suffers a witnessed ventricular tachycardia arrest and given a 150 joule shock. The ECG still shows the VT and does not have a palpable pulse. So what is the most appropriate next step? Pulseless VT.
So this is pulseless ventricular tachycardia, and patient is unresponsive following the shock. So what should be the most appropriate next step?
Further direct cardioversion current.
No, not direct cardioversion. So
Adrenaline.
the most appropriate next step for this 54-year-old man presenting with the pulseless VT following 150 joule shock, it would be the continue cardiopulmonary resuscitation.
Okay.
So this pulseless VT,
CPR.
this pulseless VT, this is treated as an shockable rhythm based on the ALS. So after delivering a shock, if the rhythm remains shockable, meaning if the rhythm still remains ventricular tachycardia, the next step would be to immediately continue the CPR for 2 minutes. The primary goal or the primary aim would be to maintain the perfusion and to provide the time for any treatment or for further shock to be effective. This defibrillation or shock, this is important, but after each shock the CPR should be resumed immediately without checking the rhythms or pulse until the after the next 2 minute cycle of CPR, as it will maximize the chances of the ROSC, return of spontaneous circulation. And adrenaline and amiodarone, they are usually given after the third shock in case of shockable rhythm like ventricular tachycardia or in case of ventricular fibrillation. And this adrenaline, this is typically administered every 3 to 5 minutes during the arrest, but this is not before the first cycle of the CPR or before the first cycle of defibrillation that has been complete. So adrenaline, this should be given after the third shock. Amiodarone, it should be given after 3 fibrillation attempt. Further direct current shock, it should only be considered after continuing the CPR for 2 minutes following each of the shock. And the lidocaine can be given as an alternative to amiodarone, but this is not also suitable here. So after the unsuccessful shock, especially in case of pulseless VT, the immediate next step would be to continue the CPR for another 2 minutes. So let me repeat again. So this VT, ventricular tachycardia, this is one of the life-threatening arrhythmia. So the heart will be beating very fast, preventing the effective blood pumping. So in this case, the pulseless VT, meaning his heart is not generating a pulse, or this is not circulating properly. So the immediate treatment is needed to restore the heart's normal rhythm and the circulation. So that's why he was given the shock 150 sol, which is the right step to treat the ventricular tachycardia, since this is a shockable rhythm. But after the first shock, he's still in VT, ventricular tachycardia, with no pulse. So the next step based on the ALS criteria would be to go for immediate CPR. After delivering the shock, CPR should be resumed immediately for 2 minutes, regardless of whether the shock has worked or not. And this purpose of CPR, it would be to keep the oxygenated blood flowing to the vital organs, especially to the brain and the heart, while preparing for the next step. And we'll be reassessing after 2 minutes. You will reassess whether you will reassess the rhythm and the pulse. If the rhythm is still shockable, then another shock may be given. And in case of medication, you can either you can go for adrenaline or amiodarone, but they will come into play after the third shock. So we'll be continuing the CPR for 2 minutes. Continuing CPR is the most appropriate next step, considering that the return of the spontaneous circulation hasn't accepted. It should be continued for further 2 minutes with as little interruption as possible. Adrenaline should be considered once 3 cycles have been delivered with no effect, alongside 300 milligram of amiodarone, and adrenaline after 3 cycles of CPR, and as well as the amiodarone.
Sir, in which condition we give a stacked shock? We give a stacked shocks, no? Like three in a series, 3 cardioversions, stacked shocks. So which condition will give that?
Oh, sorry, I don't have any idea on the stack shock. I need to check this. I will let you know later. Okay.
Okay, sure.
Okay, next one.
What is the patient's calculated osmolarity?
So how to calculate osmolarity? Formula: 2 into sodium plus
Into sodium,
2 into potassium plus glucose plus
urea.
urea concentration. All of them will be in the millimole. So 2 into 126 plus 2 into 4.5 plus 7 plus 5. So you need to calculate. So this is the 253. So how can you explain the low osmolarity in this patient?
Yes, yeah.
Yes, it can be explained by the SIADs. The patient has the features of confusion, dry cough, as well as features of hyponatremia. And there is also evidence of the pneumonia, crackers in the lead base, elevated white cell count, as well as the elevated CRP. This suggests the SIADs, which has potentially triggered the pneumonia, and patient has comes up with the hypotonic hyponatremia. So this is 253. So 2 into sodium plus 2 into potassium plus glucose plus urea concentration. And in most of the cases, they will give you the closer value. Like if the calculation is 253, they will give an option like 250 or 255. So you'll be choosing the most closer one.
What is the most likely cause of the patient's symptoms? Ostium primum ASD, ostium secundum ASD, patent ductus arteriosus, patent foramen ovale, and VSD. 29-year-old woman present with a cardiology clinic with the intermittent fast, irregular palpitation. She says she first noticed them around 6 months ago. Her blood pressure is 122 over 82 millimeter mercury, and the heart rate is 80 beats per minute and regular. She has a fixed split second heart sound on auscultation of the chest. Her lung is clear, are clear. So what is the most likely cause of the patient's symptoms?
Ostium secundum ASD.
So fixed splitting of the second heart sound. This is pointing towards the atrial septal defect. ASD can be due to ostium secundum defect, can be due to ostium primum defect. Ostium secundum is more common, and usually we can easily differentiate depending on the ECG. So in both of the condition, whether this is ostium secundum or this is ostium primum, both of them will have the right bundle branch block. In case of ostium primum, there should be left axis deviation. In case of ostium secundum, there should be right axis deviation. So depending on the axis deviation, we can differentiate, but they haven't given here the axis deviation. So since secundum is more common, we'll be going for the secundum. So primum will have the left axis deviation. The ladies are the ostium primum, and ROS, these are the ostium secundum. And in the original recall, they give almost the similar picture. Patient comes up with the features of worsening shortness of breath, exercise tolerance, irregular palpitation. Patient had the fixed splitting of the second heart sound pointing towards the atrial septal defect, and the ECG was given as right bundle branch block plus right axis deviation. So RBBB plus right axis deviation. So which AST, primum or secundum?
Secondum.
Yes, this is the secundum. ROS, right axis deviation for secundum, and ladies are the primum. The fixed split second heart sound is most consistent with the ASD, and secondum defect are responsible for approximately 70% of ASD. The palpitation may represent the development of paroxysmal AF, and echo confirming the diagnosis, and a 24-hour tape assessing for atrial fibrillation are warranted as paroxysmal atrial fibrillation, and echo confirming the diagnosis and the 24-hour tape assessing atrial fibrillation are warranted as a potential next investigation. Secondum defect may be suitable for closure by utilizing a transcatheter device. And primum, there's the ladies left axis deviation, and this is less common.
What is the most likely cause of the patient's symptoms? Lewy body dementia, multisystem atrophy, normal pressure hydrocephalus, Parkinson's disease, progressive supranuclear palsy. A 75-year-old man is referred to the neurology clinic with the recurrent backward falls and difficulty walking. According to his wife, he has also become depressed and anxious of the past few months. His blood pressure is 125 over 80 millimeter mercurial on lying and 120 over 75 millimeter mercury on standing. He has a shuffling gait. There is a bilateral increased tone on the neurological examination with a slight tremor on the left. He has an impaired downwards gaze, and the trial of levodopa had a minimal effect. What is the most likely cause of the patient's symptoms?
So we have already discussed. So this patient is having the Parkinson's disease, and this is one of the Parkinson plus syndrome. Recurrent backward fall. This points towards the postural instability. Impaired downward gaze points towards the vertical gaze pulses. So PD plus postural instability plus vertical gaze pulse diagnosis.
Progressive supranuclear palsy.
Yes, this is the PSP, progressive supranuclear palsy. Alternative name of PSP is the Steller-Richardson Olszewski syndrome.
Yeah.
And in case of Lewy body dementia, there will be visual hallucination. Multisystem atrophy will have the multiple vascular risk factor. NPH will have the features of DUG. Parkinson's disease will have the isolated features of Parkinson's disease. No features of plus syndrome. PSP is characterized by postural instability with a tendency to fall backward and impairment of downward gaze. Some features of Parkinson's disease, such as gait impairment, loss of higher cognitive function, may also be seen. In contrast to MSA, postural hypotension is not usually a feature. The prognosis is poor with a duration of symptom onset to date of between 5 and 9 years. Treatment is directed at reducing the risk of fall. So it will have visual hallucination. Multisystem atrophy will have the multiple vascular risk factor. NPH will have the DUG.
How does grapefruit juice interfere with the simvastatin metabolism? A 62-year-old man is treated with a high-dose simvastatin following a non-ST elevated MI. He is warned not to drink the grapefruit juice. So how does grapefruit juice interfere with the simvastatin metabolism?
So statin, grapefruit juice plus simvastatin metabolism interaction.
CYP3A4 enzyme inhibition.
Yeah, this is the cytochrome P450 3A4 enzyme inhibition. CYP3A4. So clarithromycin, erythromycin, grape juice, they are related to cytochrome P450 3A4, 1A2 ciprofloxacin, 2A6 floxetin paroxetine, 2C19 PPI, 2D6 opioids, and what one inhibitor is the lesinurate, and all of them are the inhibitors. So here they have given regarding the enzyme induction, but in the original recall, they gave the interaction of grapefruit juice with the simvastatin metabolism, and the ultimate effect was the decreased glucuronidation. So grapefruit juice plus statin, it will lead to decreased glucuronidation. Grapefruit juice is a potent inhibitor of cytochrome P450 3A4. This can significantly increase the bioavailability of the agent metabolized by enzymes such as simvastatin and cyclosporin. Concerning simvastatin, this can lead to muscle cramp, significant rise in the creatinine kinase concentration. In severe cases, rhabdomyolysis may be seen. So in which statin features of rhabdomyolysis is more commonly seen? In lipophilic or hydrophilic?
Lipophilic.
In case of lipophilic. So which two statin are more lipophilic?
Atrovar and simvastatin.
Yes, simvastatin is most common, followed by the atorvastatin, and usually the rosuvastatin is the safest option. So next one will be our last question.
Which cranial nerve is responsible for the sensory component of the gag reflex? A 34-year-old man. Okay. So 34-year-old man is to the intensive care unit following a significant head injury sustained in a fall. His gag reflex is tested. So cranial nerve responsible for the sensory component of the gag reflex. 7, 8, 9, 10.
So
and
sensory
11.
component of the gag reflex.
Glossopharyngeal.
9. Glossopharyngeal.
Yes,
Glossopharyngeal.
this is the glossopharyngeal. And the motor component or the efferent component.
Vagus nerve.
Yes, this is the
10.
vagus nerve. So afferent or sensory pathway, this is mediated by the ninth cranial nerve, glossopharyngeal nerve, and efferent or motor pathway, this is mediated by the vagus nerve. So you can remember gag as in gas. So G for glossopharyngeal, A for afferent, S for sensory. And the movie, M for motor, V for vagus, E for the efferent. So this gag reflex, this is one of the protective reflex of the throat, which is triggered by touching the posterior pharyngeal wall, and the sensory information from the pharynx. This is usually transmitted by the glossopharyngeal from the pharynx or posterior pharyngeal wall via the pharyngeal glossopharyngeal nerve, and it will carry the sensory information. And the motor response, this is initiated by the vagus nerve. So afferent sensory by the glossopharyngeal nerve, and efferent or motor by the vagus nerve. The gag reflex requires an intact sensory and the motor component. The sensory component is the cranial nerve 9, which supplies the posterior oropharynx. The motor component is supplied by the cranial nerve 10. Assessment of gag reflex, this is the component of the brainstem that testing. So afferent, it would be elicited by touching the posterior pharyngeal wall, mediated by the glossopharyngeal nerve, and this glossopharyngeal nerve, it will carry the sensory information from the posterior 1/3 of the tongue, the oropharynx and the tonsil, and this is responsible for the afferent limb of the gag reflex. So this will be the end of our discussion for today. So any question from anyone?
Sir, can statin have interaction with cranberry juice?
Cranberry juice.
Usually warfarin
I
has
think
interaction with the
warfarin
cranberry
has
juice.
interaction with cranberry juice.
Warfarin has got interaction with the cranberry
In
juice.
January 2024 recall, there was a question with statin and cranberry juice.
More commonly, okay, regarding the statin, I'll check it and I'll let you know in the group later on. With the crane, warfarin is more commonly interact one.
As all juices are CP450 inhibitor, can this explain the statin has interaction with cranberry juice?
So actually, they have the subtype like the 3A4, 2D6. So this type of subtype, they are usually responsible for the interaction. So when they match perfectly, there will be more interaction, and when there is less matching, they'll have the less degree of interaction.
Sir, this is not related to this, but can NSAIDs be used in asthma?
If this is well controlled asthma, with medication, then in that case you can go for NSAIDs. It should be well controlled asthma, but if this is not well controlled, then in that case you can go for NSAIDs.
Okay, sir. Thank you.
Okay, anyone else? There is no further question, then we'll conclude here. Okay, thank you everyone.